today's insights. So let's get started. Before we dive in, let's take a moment to reflect on the highlights from yesterday. We heard some incredible perspectives from Professor Dr. S.P.K. Jaina sir, Professor Dr. Rakesh Kumar Tripathi sir, and Dr. Paula Z. Bartholomew. The discussions sparked great conversations, and I hope you found them as inspiring as I did. Today, we will continue that momentum with even more thought provoking sessions. Now, to kick off the day, we have Dr. Mustafa Nadeem Kirmani sir joining us to discuss navigating positivity in VUCA world. Dr. Mustafa Nadeem Kirmani sir is a distinguished clinical psychologist, is an associate professor and head of the Amity Institute of Clinical Psychology, Amity University, Haryana. He previously served as the head of the Department of Clinical Psychology, Faculty of Behavioral Sciences, SGTU, Gurgaon. He has published numerous research papers in peer-reviewed journals, authored 2 books, Psychology of Religion and Spirituality, and contributed 40 articles on mental health. He has presented multiple papers at international, national, and regional conferences, winning Best Paper Presentation Awards. Dr. Kirmani has attended numerous workshops with accredited professional programs. Please give a warm welcome to Dr. Kirmani, sir. The session will be chaired by Professor Dr. Rakesh Kumar Tripathi, sir. Dr. Rakesh Kumar Tripathi, sir, is a distinguished clinical psychologist with extensive contributions to mental health research and practice. He also serves on the editorial board of the Journal of Gerontology and Geriatric Research and reviews for leading journals. Dr. Tripathi has received multiple awards and, uh, and the S.C. Gupta Young Scientist Award, Senior Research Fellowship from ICMR New Delhi. With 50 plus publications in peer-reviewed journals, 3 books and 2 book chapters, he actively contributes to psychological research. Please give a warm welcome to Professor Dr. Rakesh Kumar Tripathi, sir. I would now like to invite Dr. Kirmani.
So good morning, everyone. I have to acknowledge first that I am extremely grateful to Zaidi sir, Amity University, Lucknow for giving me this opportunity to come over here and share my understanding of what this topic is like. I'm basically I have limited knowledge, but I would like to share to the best of my abilities what I know little things in this. So the topic is how to navigate, how to be positive in what is known as, I tell you what is that, VUCA situations. So number one thing, I would like to be very practical, and there is an important quote which says there is nothing permanent in this world except change. We all are changing. The only thing that is permanent is change. And one thing is very practical. I do not know what is going to happen at 10:05. 10:05 पे क्या होने वाला है इस दुनिया में मुझे नहीं पता. Right? Do we know that? No, we don't know. What will happen at 11 o'clock today? We do not know. What will happen in the evening? We do not know. So, but many things we know. So why I'm saying this, we need to train ourselves. This is a world which is to some extent predictable, and this is a world which is some extent unpredictable. So how do we navigate ourselves in situations which are unpredictable situations? So that is what I'm going to discuss today. So, I am a clinical psychologist, so I always start with clinical psychology things. I always say that my psychology is in my brain and clinical psychology is my heart. So nowadays, clinical psychology has incorporated what initially it was not happening, any strength-based models. Initially, we were focusing, and we are proud of that we are focusing on negative aspect of human existence, depression, anxiety. But nowadays, what we have been doing over the last maybe decades, more than decades, that we have started focusing on flourishing conditions, what humans know rather than we do not know. That is the basis of clinical psychology nowadays. And we call it positive clinical psychology. Illness model, and the pioneer work was done by Seligman. Yeah, strength-based model. Initially, in a clinical setup, we ask, "Aapko kya dikkat hai?" You know, but now we have started rephrasing our questions. What are you good at? And that is a paradigm shift that is happening in the field of clinical psychology. So we need to understand that human beings are hardwired to 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 prepare themselves in negative situations. We are hardwired to adaptiveness to protect us. For example, when you go out and you do not know the situations, we first try to act in an adaptive fashion. अगर आप कहीं नई जगह जाते हो, आपको नहीं पता होता है, तो आप पहले अपनों को protect करते हो. How, if something bad happens, how do I save myself? This is very natural, and this is a model which is being derived from evolutionary psychology. So having first negative thoughts is not bad because it protects us in the future. That is also the base that we all should know. Now, the basic model that I'm going to talk today is what is known as VUCA model. And this is the first time I'm thankful to Zadi sir, who has given me this opportunity to talk about this. VUCA stands for volatility. V stand for volatility, uncertainty, complexity, and ambiguity. It means that all these situations make this world very threatening, very challenging, and very ambiguous, and actually which makes our mind difficult how to adapt to these situations. How we can adapt to these situations, I'm going to discuss this thing. Volatility refers to rapid change. Change, as I said in the beginning, is a very natural phenomenon, and changes keep happening. Now, if you know a very classic work of Toffler, who wrote a book on future, the title of the book was Future Shock, 1970, in which he described that how the world is going to be in the next 30 or 40 years. He has talked about how technology can be highly devastating, and how we can prepare ourselves to adapt to those situations which are emerging. And he talked about in 1970s in a classic book. It's worth reading, The Future Shock. He also wrote a book, Rethinking the Future, 1998. And he also, actually, the thesis of his work is prepare ourselves for the challenges that is coming up in future. Another sociologist, Ogborn and Nimkov, they have talked about what is known as material culture and non-material culture. Material culture is something which is concrete, and non-material culture is something which is very abstract. For example, what we wear, what we eat is something material culture. Our values, our behavioral things, our thought process are non-material things. What these scientists, social scientists have said, that with timings, it is easy to change material culture, but along with that, it is very difficult to change non-material culture. But what I say in my usual presentations, coat tie पहनना is change लेके आना is easy, but क्या आप अपने thoughts को उसके साथ match कर पाते हैं is a challenge, because wearing a dress is something with material, and along with that, non-material cultures को change करने में time लगता है. And this was talked about by Ogmore and Limpoff. And he talked about notion of cultural lag. Another important work which worth reading for understanding is a very important anthropologist, Geets and his work on culture that we all need to understand. Uncertainty is about, as I said in the beginning, I do not know what is going to happen at 10:30. So uncertain, this is also an uncertain word. In fact, the world has been uncertain from the beginning, but nowadays the uncertainty level has increased. And the classic work on this, I'm quoting it from clinical psychology work. It was a classic work done by Brady on monkeys. And monkeys were given an experiment was done, and they were placed in situations wherein they were giving some sense of control, and in the situation there was a situation in which they have limited control. Limited control means uncertainty, and major amount of control means certainty. And Brady found that in situations wherein the monkeys were put in uncertain situations, they have a sense, they found that their physiology changes. And the monkeys used to have a lot of ulcers when they were put in uncertain situations. Very classic experiment in physiological psychology and the work done by Brady. Another work, as we all know, Martin Seligman's work on uh, what is known as learned helplessness, a classic experiment on dogs, that when we know that whatever I do, it is not going to have any effect. So we stop, we minimize responding to come out of those challenging situations. These are classic experiments being done in clinical psychology field. We should know that actually. Uncertainty, complexity, information overload. We have a lot of information coming up and we are all loaded with those situations. So how to tackle with this, I'm going to talk later in my presentation. A lot of information coming from different sources, multiple sites leading to difficulty in decision making. एक ही समय में 5 situations हैं, 5 information आ रही है. अब आप कैसे करना है? How to deal with those situations? It is a challenge. And I'm going to talk about how to deal with the challenge. Ambiguity, ambiguity is, we all know, it's not clear situations. What time the something is going to finish, what time something is going to start, we do not know. The ambiguity is a variable which always creates, most of the time, it creates a lot of, anxiety and stress among people. So how do we deal with ambiguous situations? That is also my topic. This is also I'm going to talk about in my later presentations. So now I am going to talk about how to manage all these VUCA situations. Now, goal is to have a strategic planning to achieve a desired goal. We all have goals of everyday situations. So what strategies that we will be using to tackle all those 4 situations? The output, the major outcome will be desired goal to achieve a particular thing that we want to achieve or I want to achieve. So for that, it is very important to have flexibility in our thoughts. Now, nowadays we are talking about a researcher and scientist, social scientist. She talked about mindset, fixed mindset, and growth mindset. Fixed mindset is something that you are fixed. चीजें ऐसे होनी है तो ऐसे ही होनी है. Flexible mindset is something that which creates your neurons, which creates which gives an experience to your neurons that you start thinking in multiple ways. This thing can be done in many ways. So flexibility in thoughts, flexibility in behaviors are very important to deal with these VUCA situations. Brainstorming, we all know brainstorming is a concept given by Osborne that we train people to keep coming, whatever thoughts come to your mind, do not suppress any thought, let them come, let them go. So when we train people through brainstorming, actually we are not telling them to stop, this is not right, this is only way of thinking. So brainstorming is also one method by which we can bring about flexibility in our thought processes. So positivity is also there in my presentation topic. So positivity is something in which we try to create situations in which people start thinking positive, experiencing positive emotions, engaging in, like for example, engaging more altruistic behaviors, pro-social behaviors, like kindness, generosity, etc. And it requires training. Please understand that positivity uh, we cannot produce positivity just by lectures, as Janus was talking about yesterday. It requires experience and training. Now, volatility, as I said in the beginning, volatility is one thing, which one variable. Volatility means sudden change in situations, you know. So experiential training is of varied experiences, is something which makes our mind flexible and which also prepares us to deal with negative situations or threatening situations or something which can happen suddenly. Now, very simple example I have quoted here, that we should train ourselves in, suppose there's a summer season, we should tell a child or anyone to sleep without a fan. Pasina aa raha hai, aane do. Sleep with fan. Fan is running, you sleep. Sleep with cooler. Cooler हवा की ठंडी हवा आ रही है. Sleep without cooler. Sleep with AC. Sleep without AC. So when you experience all those things, sleeping without a fan in a summer season sometimes, so it actually train your neurons to adapt to those challenging situations. It's a change. जैसे आप लाइट जाती है तो एकदम हमने देखा है, अरे लाइट चली गई, लाइट चली गई, लाइट चली गई, एसी बंद हो गया, एसी बंद हो गया, खोलो कूलर खोलो. ये हमारे रिएक्शंस क्यों आते हैं? क्योंकि हमने अपने माइंड को ट्रेन नहीं किया है कि हाउ टू अडैप्ट. सो इफ वी ट्रेन पीपल, इफ यू ट्रेन चिल्ड्रन टू हैव वेरिड एक्सपीरियंसेस ऑफ चैलेंजेस, these reactions can be minimized and it can generate a sort of positive adaptation in the situations. Another important thing is that a very practical thing that can be done, continuous dialogue of the stories. We need to have a dialogue with people that how sudden changes, when people experiences a lot of changes, sudden changes, and how they have successfully come out of those changes. Stories, sharing the stories, positive stories of people who have experienced a lot of changes in their life, sudden changes, but they have come out of those changes successfully. So having a dialogue through stories is also one method by which this volatility can be help people to become more adaptive in their behaviors. Cognitive reframing. Cognitive reframing is something, is very simple training program. It's actually when you change the lens. आपने अपना चश्मा बदल दिया, सिचुएशन वही है, आपने उस सिचुएशन को दूसरी तरीके से देखा. Now, for example, the situation is very challenging, and rather than seeing the situation as challenging, you start thinking as, oh my God, I am so happy that this is an opportunity for me to learn and relearn and unlearn many. When we reframe ourselves in the different situation, to see the situation in a different angle, it will help us to become more flexible and it will help us to adapt to what is known as volatility. Okay, I can give my own example. I always teach by example. I discussed with example. When I got this UCA model, I was initially very little anxious, but I reframe myself that it is a great opportunity for me to understand what is UCA for myself. So it will help me to learn for me better what is UCA so that I can share those things with me. So convert your challenges into opportunities. This is very, very important. जिसको आमतौर पे पॉलिटिशियंस बोलते हैं आपदा में अवसर, उसी तरह की एक चीज है, uncertainty. Uncertainty, as I said, we all have situations in this world which is predictable. Sometimes we have situations which are uncertain. So how to tackle with that? Having the training of experience of uncertain situations. We have to train people to have uncertain situations. Okay. For example, we know that if you are taking a child to a platform and the train timing is suppose 11 o'clock. Okay. You don't tell the child the timing. You just tell the child, we don't know what time the train will come. So have the child experience those waiting times. When the waiting time the child will experience, so it is uncertain situation. बच्चा सोचेगा ट्रेन कब आएगी, मम्मी कब आएगी, पापा कब आएगा ट्रेन. But when he's experiencing those uncertain situations, it will helping the child through his neuronal aspect. Neurons सीखेंगे कि इन situations को कैसे adapt करना है. So that is also one thing which is important. And another thing which is important is training in alternative strategies. We have हमने क्या किया, अपने ब्रेन को बड़ा रिजिड बना दिया है. हम I give examples like neurons आपस में बात करते हैं कि बस इसका एक ही सोल्यूशन है. न्यूरॉन्स में बात ये नहीं होती इसके कई सारे सॉल्यूशंस हो सकते हैं. न्यूरॉन्स हमारा वेट करते हैं. वी आर मेक इन सच अ वे टू मेक मोर फ्लेक्सिबल. जब आप न्यूरॉन्स को एक ही एक्सपीरियंसेस देंगे तो न्यूरॉन्स को ये नहीं पता होता कि हाउ दे कैन अडेप्ट टू डिफरेंट सिचुएशंस. तो if we can train our brain, actually it's a train of our brain and neurons to have alternative solutions, or solution number 1, solution number 2, solution number 3, and also those has to be experienced by a child. So if we do that in people, if we do that in children, so we can make them better so that they can adapt to uncertain situations. Another thing, as I said before, sharing success stories of children, with children who who read that how uncertain situations were tackled by people. But जब वो story सुनते हैं कि in uncertain situations से लोग बाहर कैसे निकले, so it gives a message to them that how they can come out of that. It gives a positive message. So sharing positive stories, sharing successful positive stories with children is also very, very important. Complex. This is a very complex world. Is दुनिया इतनी simple नहीं है जैसा हमें दिखती है. So we have to train. Again, I will put neuropsychology here. We have to train our brain. We have to train our neurons that this is not a simple thing. Complexity for that. So what we can do that? Training a person in multitasking. You are doing this thing, at the same time, you might have to do this thing. Task 1, task 2, task 3. So when we are training the person, when I say training, it actually means experiencing. The child or person is experiencing many things at the same time. So neurons are adapting, slowly adapting how to do multitasking. So that, and now we call it neurogenesis, and research have shown that neurons adapt very quickly if they get new varied experiences. So this is also very, very important. Another important thing that is important for all of us to deal with complex situations is training in goal setting. हम अपने goals set नहीं करते. Smart model as it is taught in this world, a smart model of goal setting, is like goal has to be very specific, measurable, achievable, realistic, and time bound. So when we train people in setting of goals, very specific goals, very specific manner, so it becomes easy for them to deal with complex situations. Okay, we don't need to have overgeneralized statements. We need to have very, very specific. For example, I am presenting here, what is the goal? What time I have to come here is the goal. What I have to do in the morning is the goal. So if we break the goals into smaller steps, it becomes very, very easy. So goal setting also helps us in dealing with complex situations. Ambiguity. It is again a part of VUCA model. Ambiguous situations. TAT हमें help करते हैं. Ambiguous stimulus होती है, वो एक clinical model है. How do you interpret? That's a projective model that I'm not going to talk about. So ambiguity is when you do not know what is going to happen. How to deal with that? This is my clinical understanding. I think if we train people in frustration tolerance training, अगर आप लोगों को frustration को कैसे tolerate करना है, उसकी training दे देंगे, तो मुझे लगता है कि ambiguity situation से उनको deal करना आसान हो जाएगा. And the classic work in this area was done by Walter Mischel. Walter Mischel, a psychologist, actually has done a lot of work on personality, what is known as marshmallow experiment. What he did is, बच्चों को उसने chocolates, marshmallow दिखाया, and he said that you will get a marshmallow if you have to be in the room, but don't eat it. ये आपको chocolate खानी नहीं है. Although you may be hungry, but don't eat. Okay, and those who can wait for some time, they will get a better reward. आपको और बढ़िया चॉकलेट मिलेगी. अगर आप चॉकलेट भूखे हो, चॉकलेट दिख रही है, रूम के अंदर हो, लेकिन चॉकलेट खानी नहीं है. What is happening? Child will get frustrated. Why? Because the goal is to eat, because he's hungry, but still he's able to manage his hunger by tolerating frustration. So people have found that, if there is frustration tolerance increases, it becomes easy for people to deal with ambiguous situations. So now another important thing that is important here is solution-based talk. Our talk, if you observe, our talk is mostly problem-focused. इस दुनिया में ये नहीं है, आज वो नहीं हुआ, आज ये नहीं हुआ. So if we can train ourselves, if we train our mindset, children, adolescent, ourselves, children, that let us be focused, let us talk about solutions, let us talk about what is a possible solution of this. So what will happen is your neurons will start generating solutions if we change our problem-based talk to solution-focused talk. That is very, very important. Solution-related words activates prefrontal cortex. This is research. Rational decision making and affective emotion regulation. अगर हमारे संवाद में, बातचीत में solution focused words होते हैं, तो prefrontal cortex activate होता है. Prefrontal cortex is something which actually helps us in decision making. So we have to convert our language. I always say therapy का major tool is language. So if we change the language, if we change the words from problem focused to solution focused, we can bring a lot of changes in our behaviors, and we can make people very solution focused, thereby more adaptive to complex situations. Solution focused questions. We have to create a dialogue in which questions has to be solution focused. For example, what are your best hope for these situations? A situation is very challenging, and what we need to have a dialogue. What we can ask, हम क्या पूछेंगे, उससे पूछेंगे, what are your best hopes for these situations? इस situation से आपकी क्या best hopes हैं, क्या best निकाल सकते हो, कैसा? Means we have to change the language, we have to reframe the questions and ask more solution focused questions. When we do that, we will generate a sort of a mindset. Mindset is a more psychological word, but it will bring a change slowly in a neuronal structures. Research have shown that brain is very adaptive. आपके जो शब्द होते हैं ना, जो शब्द बोले जाते हैं, वो न्यूरॉन्स लेते हैं, और कंटिन्यूअस सेम शब्द बोले जाएं तो न्यूरॉन्स अडेप्ट हो जाते हैं. Same shaped in this context are more solution focused. So if we change the dialogue from problem focused to solution focused, we can bring a lot of changes in our behaviors, more flexible behaviors. So that will become a training program for all those who, all of us in fact, we all face VUCA situations. So these are the things which I have in my mind based on my clinical experience, limited knowledge. So this is all about how to inculcate, navigate through positivity, the VUCA model. Thank you.
Hello. Yes. Now, house is open for question, clarification, and comments to the Dr. Mustafa Nadeem Kiramani.
Please ask anything that comes to your mind. It will help me to learn and unlearn many of my own things.
Actually, he has explained very well about the VUCA and the negativity, how it can be navigate with positive things in our life. He explained very well with the practical examples. If anybody want to ask any question, you're welcome. Yes, please.
Yes, please.
Give him the mic.
I'm Divyanshu from MA Clinical Semester 2, and I wanted to ask, we are more focused, as a community, we are more focused on problem-based thinking. You go with the solution and people will tell you 10 problems about your solution. So how to go forward with that?
Change the dialogue.
And like with more, what kind of words do we use to present a better dialogue of solution?
For example, you just, that depends on the context. Now, if a depression person comes to you, first appreciate that he has come to you. I am very happy to see you here in my clinic. Okay, rather than what has happened, आपको यहाँ क्यों आना पड़ा? आप even small behaviors which are being done by the client, which are successful behaviors, positive oriented behaviors need to be encouraged. Behavioral action. Then your dialogue has to be very solution focused. जो examples आप दोगे, you ask the person, I would like to know how have you navigate yourself from those challenges. So we will change the dialogue from problems to solution focus. It will take time, but it will definitely happen.
Thank you, sir.
Yeah, welcome.
Yes.
Hello, sir. I'm Chandrakash from AIRS department.
Yes, sir.
So as you mentioned that we should switch towards the solution-based talk rather than the problem-based. So when there is a problem, so first step is to identify the problem and the aspects which are related with the problem. And that's the moment when we start talking about the problem, and it's a kind of chain reaction. And that's how we are going to involve ourselves more into the problem-based talk. So as a professional or as a person or as an individual, how we should avoid these kind of talk at the very beginning?
Okay. See, as a because my training is clinical, and clinical training always trains us to focus on problems. So we need to understand problem is very important. We need to acknowledge problems also. But after having understood the problems, acknowledging the problems, we have to navigate the client to come to a solution talk, solution focused talk. Okay. How to do that? That requires certain sort of skills and training, but it can be done. Research have shown that even people with schizophrenia can be trained through solution focused therapy. It takes time, but it can be done. We have to understand and acknowledge. We don't know to disregard it. We need to understand and acknowledge.
Okay, sir. Thank
Yeah.
you.
It was nice presentation by Nadeem, Professor Nadeem Kirmani ji. Thank you very much for enlightening us for the VUCA word. VUCA stands for V, volatility. Everything is uncertain in our life. And other thing is uncertainty, and third is complexity, and fourth is ambiguity. Please come here, Dr. Nadeem Kirmani. Please sit here. Okay. He talked about the illness model to shift paradigm shift to the wellness model. And there is very difficulty for us to deal with the situation which we faced. We are still in denial position. What he told about that acceptance is very important. Acknowledgement is very important, whether it is problem or whether it is not problem. The first step is acceptance, acknowledgement of the things which we can do after taking and gaining lot but knowledge. If we are not knowledgeable about what is our limitations, what is our strengths, we cannot think in a positive way. The first thing is knowledge, gain knowledge. And this kind of forum, the community health program, international conference, is giving us opportunity to gain knowledge about the different aspects of the community health, mental health, and lots more thing. And yes, VUCA model is yes, it is also a new thing for me. And in previous conferences, Professor Zaidi used to give me the different topics to present. Now this time, this is given to the Mustafa Nadeem Kirbani, and he has given a wonderful talk regarding this. Okay. Now I want to say one thing, and after that I will close my comments. That in Srimad Bhagavad Gita, there is written the karma devadhikaraste ma phale sukadachana. Ma कर्म फल हेतु गुरु मास्तत् कर्मणि. मतलब आप फल की इच्छा के बिना what is going to be the results? If you are engaged in your activity, purposeful activity, then you will got out from the uncertainty. And this is the mool mantra. And knowledge is always required to do the karma in the right direction. So thank you very much for the organizing committee to giving me the opportunity to chair this session. Okay, thank you. Dr. Nadeem.
I have the permission from the chairperson, sir. I just want to say the work, one philosopher said, I am not here to teach you. Teachers should not teach. So what they should do, they should motivate people to think. They should think, students should think, clinicians should think, and then find out the solutions. That paradigm we have to start developing in the educational institution, motivating people to think rather than giving them answers. That is, I thought I should just share this with the audience. Thank you.
Thank you, Dr. Kirmani, for your nice words of wisdom and presenting the lecture.
I think we can all agree that this was an extremely insightful session. Thank you, Dr. Kirmani, and thank you, Tripathi, sir. I would now like to request Professor S.Z. Ed Zedi, sir, to please felicitate our speaker and our chairperson. Up next, we have Dr. Vivek Agarwal, who will be exploring challenges in child and adolescents healthcare program and role of community. Dr. Vivek Agarwal is the professor and head of child and adolescent psychiatry at KGMU, Lucknow, India. A distinguished researcher and clinician, he has made significant contributions to the field of mental health epidemiology, psychiatric care accessibility, and the socio-economic impact of mental disorders. His research includes highly cited studies in top journals such as the Lancet Psychiatry, BMJ Open, and the International Journal of Social Psychiatry. Key works include his contributions to the Global Burden of Disease Study and the National Mental Health Survey of India, which have shaped mental health policies and interventions in India. Dr. Agarwal's expertise in child psychiatry and his commitment to mental health research continues to drive advancements in psychiatric care, ensuring better access and treatment for vulnerable populations. We welcome you, sir. Our chairperson for this session is Professor Dr. Aleem Siddiqui, sir. Professor Dr. Aleem Siddiqui, sir, is a distinguished psychiatrist and researcher with significant contributions to schizophrenia, endophenotypes, medication adherence, obsessive compulsive disorders, and neuropsychology. His work spans psychopharmacology, mental health interventions, and cognitive impairments, improving psychiatric treatment outcomes. He has provided valuable insights into schizophrenia prodrome, medication adherence, and bipolar disorder, while also exploring obsessive compulsive spectrum disorders and epilepsy related psychiatric conditions. His research on delusional drug dependence and nocturnal enuresis highlights psychosocial factors in psychiatry. Dr. Siddiqui has collaborated with esteemed researchers and published extensively in journals such as the Indian Journal of Psychiatry, American Journal of Therapeutics, and International Journal of Advances in Medicine. His pioneering research continues to advance psychiatric disorders, neuropsychology, and clinical interventions worldwide. We welcome you, sir. I would now like to invite Dr. Agarwal to the dais.
Well, very good morning to all of you. And I am very thankful to Dr. Jari Saab and his team for inviting me to give this talk. So, as I work primarily with children, so this is a very, very important that we learn how to manage children in community. Oh. So first, let's understand what is the magnitude of the problem. So we know that some 10 to 20% of the children, they suffer from psychiatric disorders. 50% of the psychiatric problems in adults, they have onset before 14 years of age. And at least in our country, suicide is a leading cause of death in adolescents and young adults. Second leading cause, second to accidents. And this is not all. We have large number of children who are not diagnosed with psychiatric disorders, but they have problems which require psychological help. Then there are children who are out of a school system. They are in slums, poor children who are not able to attend school, or large number of children who drop out of the school in early age. So most of the community work has gone primarily into the schools and much less addressing the problems of children who are out of a school system. Now, what is the availability of manpower to deal with all these things? So if we take the manpower per lakh population, so psychiatrists are only 0.3. Psychiatric nurses are 0.12. Psychologists and psychiatric social workers are 0.07. So we are highly inadequate in manpower to deal with such a magnitude of the problem. So in other words, the healthcare system can never be able to address the problems of or be accessible to such a large number of children. Then what are the challenges? Despite such a large number of problems, why people are not coming to seek treatment? So one is the stigma. The stigma is still, although much reduced, but still plays a lot of power. Stigma has that prevents from that prevents people to seek help. Another is lack of access. So people come to us from far-flung areas, as far as say 500 kilometers, 600 kilometers, even more. So mental health care is not accessible to all in their vicinity. And there is lot of poverty. So people are not able to again travel so far, traveling so far, purchasing medicines, seeking consultation. All these things cause lot of financial burden. And poverty is somehow related to more burden of mental health problems. Poverty is one of the reasons. So it works like a vicious cycle. So they are not able to access healthcare. And this also affects the adherence even if they come to us once for a treatment. So treatment requires long-term commitment. So adherence to treatment follow-up is poor. And because of the large load, the offer of psychological treatment is very, very limited. We are largely working on the medical model. क्या प्रॉब्लम है ये दवा खा लो. So psychological help is very, very limited, very poor. So often that leaves much desired because medications have their limitations in at least helping a person with mental health problem. So why do we need community care? So community care is required that it is available in the vicinity of the person. It should be easily accessible. It should be cost effective. अगर बहुत costly है care तो फिर adherence will be a problem. And the community care should be developed by the participation of the community कि उन्हें क्या चाहिए, किस तरह की care they want. We never develop the care or the hospital based on the feedback from the community. It is planned somewhere, it is established, and then it is open to people to seek access. But community might have a different plan, different requirement. It is never taken care of. Then government have so many programs. Mental health का program है, child health का program है, tuberculosis का program है. I mean, so many n number of programs are running, but they are not properly integrated into the healthcare system. is again creating problem in continuity of reaching the benefits of those programs to the larger community. And these programs again are not integrated with the socio-economic activities. So if a person who is a daily wage worker is going to the hospital and is spending whole day in getting the treatment for his or her child, his 1 day of wage is lost, which means a lot for them. So we are not taking care of all these aspects. Now, where you can, or the current programs are providing community care. So as I said, largely they are focused at schools. Some programs, they reach out to the patients at their homes. Some are working in the community. So Sangat, which is a NGO at Goa that does a lot of work with community. Similarly, large number of NGOs, SCARF at Chennai, it is working in community with the patients of schizophrenia or psychosis. Then some models have been developed for digital health. But again, they have not been scaled to the community. What services these programs are providing? So mental health awareness, what disorders are, what are the symptoms, what are the mental health disorders, where they should reach to help. Psychoeducation about the illnesses. What is the symptoms of a particular illness, what it can lead to, what are the treatments, those kind of things. Some are offering rehabilitation services, so persons with disability. So teaching them some skills, working on their cognition, skill training to earn the livelihood. So there are centers who are training children, say for example, intellectual disability, to work in a bakery to make products or to make products of wax, candles, diyas, these kind of skill training. Case management, this is basically refers to home-based care. So patient has been treated in the hospital, discharged back to his home, and then some social worker or psychologist is reaching out to those patients at their home so that they continue with the care. Psychological treatments. Some psychological treatments are being offered, especially with the advent of digital services. So large number of apps have been developed to provide psychological treatments in the community. And some of the NGOs or the lay persons have been trained to give psychological treatments in the community. Who are the So community health workers have been targeted. So everywhere I go, everybody wants to train ASHA. तो मुझे लगता है कि आशा जो है वो पता नहीं कितना काम करेंगी. Everybody wants to reach out to आशा कि आशा ये डिलीवर कर देंगी, आशा ये प्रोग्राम भी कर देंगी. And आशाs are already overburdened with large number of delivery of government programs. But everybody is aiming for ashas. Anganwadi workers, ANMs. Some largely related to children are targeting teachers to deliver the programs at the schools. Some are targeting other health professionals, especially related to advocates, judiciary, police personals related to juvenile justice system and the POXO Act. Some are using religious leaders. They are targeting or trying to involve the religious leaders, especially reducing the stigma and seeking help. Then some few programs have targeted the lay persons in the community. So they have been trained to deliver simple interventions. Peers have been trained to deliver simple interventions to the children. Some of the examples are life skill education. Have you heard of that? Large number of people are trying to engage or train school teachers to deliver life skills at their schools to the children at large, targeting the whole school. So life skills are like creative thinking, critical thinking, problem solving, handling emotions, coping with stress. So all these things are being taught through the stories. So this is a very good program. Gatekeeper training is a program for suicide prevention, again targeted at whole school. So this is beyond teachers. I mean, teachers are definitely part of it, but it also involves school management, counselors, and other school staff to engage with children, especially whom they find they are distressed. This is a very interesting program, that is Dawa Dua project. So this program was initiated in Gujarat at a dargah where religious leaders, preachers have been engaged to motivate patients seeking help. So clinic was opened right there only. So patients are allowed to take dua as well as dawa from the clinic. Because large number of people suffering from mental health problems, they go to such mazars and seek divine blessings for their improvement. So again, this is a very good program. Now, as I said, for children, largely programs are targeted at schools. So schools, why? Because you get access to large number of children. And if the programs are targeted at whole school, so they are not disorder specific, they are targeting whole school and they are targeted for prevention and promotion of mental health, which is the need of the hour. So such programs are likely to be more successful. Programs who are teaching skills, like I gave the example of life skill education. or teaching children to learn socio-emotional skills and early intervention for behavioral problems. So these programs are likely to have long-term benefits. These are few studies I will show you. So this study was done in Goa, in the community, in the rural as well as urban centers. So this involved schools also. So school, may I have the water, please? In schools, teachers were trained, while some peers, that is, the children among the children, were taught to give certain program. So this was implemented over 12 months. So it involves peer education, teacher training, and health information. Now this program was more acceptable in the rural community than the urban community. So urban people were not very receptive to this program, especially led by the peers in the community. So, yeah, okay. I thought I had less slides. So this program was successful in delivering the outcome was greater knowledge and attitude about emotional health, lower levels of suicidal behaviors, and is increase in skills. This program was carried out in Egypt, targeted out of school girls. This was multi-dimensional community-based program targeting life skills to the girls, functional literacy and recreational opportunities. And this took 4 times a week for 30 months in a group. And the program was largely carried out the male members of the community related to those girls. So there was significant improvement in social participation. Girls in the program significantly more likely to know about key health and the rights issues, higher on gender role attitude index. So their self-esteem has increased. This program was carried on in the South Africa. Women aged 18 years and over. This program, why I'm showing it to you, because this also had a component of giving small loans to the women to start some earnings. So microfinance was part of this program. So this was cluster randomized trial, 4 villages and 2 years. So there were control villages also, and there was significant improvement in empowerment among women. In the microfinance group showed so significant improvement in intimate partner violence, HIV risk behavior, and economic well-being in the villages which were offered these all leg of programs. So digital interventions, briefly, I will talk about it because these are very, very important, especially in our country, to access the remote areas. So a doctor sitting in at KGMU can access the remote areas through primary care centers and offer treatment. So such programs have been developed, but they are not operationalized. These can be very helpful in monitoring especially high-risk behaviors like suicidal patients. They can be monitored over telephone, and media can be used to increase the awareness of mental health problems in the community. What is the problem in the implementation? Although these programs or the studies have been done, but they could not be scaled to the larger community. Why? Because cost. Cost is enormous to carry out such programs in a larger community. And as I already told you that it creates a burden on existing healthcare workers, as I gave you the example of Asha. And it also leads to low motivation for the lay workers, and at times, especially with home visits, the community feel stigmatized that such person is visiting our home, that we are being identified. So these could be the problems of such programs. So community care is important in continuity of care as well as filling the gap in the care. Future implementation will require more use of technology to reduce cost and wider reach. Thank you. These are some of the references. Thank you.
Thank you so much, sir. It was a very elaborate. Please, Ajay. We are open for question answers. Any comments? Till the time you are thinking about questions, a few thoughts from myself. So we are today sitting in a hall. We are not working in a community. So what we are doing is opposite of community work. अभी हम क्या कर रहे हैं? We are trying to prepare ourselves to go into the community and work. So कैसे कर सकते हैं हम लोग? So just as I was listening to sir's lecture. So 2-3 important things are there. First of all, your knowledge should be up to date. If you are working in a field and you are working on borrowed knowledge and you are taking flip-flops and gaps, so it will always reflect when you go out in the community. Public बेवकूफ नहीं है, उसको पता है कि किसको कितना आता है. So if you are update, then you will be a good worker in the community. Then how you present yourself. So आज नहाकर कौन कौन आया है? हाथ उठाए. Thank you, very good. So कैसे हम अपने आप को रखते हैं, कैसे हम प्रेजेंट करते हैं? You are an ambassador of mental health. तो अगर आप कम्युनिटी में जा रहे हैं, you are presentable, then you are a good good worker in the community. Then try to engage in many things. Try to engage with NGOs, try to engage with social networks. Social media इतना important tool है. In fact, elections are won and lost. Elections mean the general elections. So इस tool को हम use कर सकते हैं. So going into community, अगर हम सिर्फ थोड़ा सा अपना दिमाग लगाएं, अपनी emotional intelligence develop कर लें, अपनी academic skills को own कर लें, अपनी personal growth कर लें. So if you are growing, the community will grow with you. Okay, तो सब लोग अपने अपने सुधार कर लें, community में अपने आप सुधार आ जाएगा. Thank you so much. So we are open to question answers. Any comments or questions? Please, ma'am.
Thank you, sir, for such a wonderful presentation. You gave me a lot of insight. But the comment which you gave, I agree with you that we have to be presentable. But I have not worked much in community. I believe you must have. But if we dress up in a way which is threatening to them, if we go,
Then you are doing a disservice.
yeah. So we have to dress up nicely. We have to be presentable. But I think the more we, uh, treat them, we dress up in a way they dress up and talk in a way they talk. I think that is more desirable than,
You take example of few prominent politicians of the country.
yeah.
So when they go to Assam, they wear that sort of pagdi. So when they go to Bihar, the angocha is there. So you have we had a previous chief minister of Bihar who used to milk cattle on video. So क्या करना है हमें अपना जो मेंटल कनेक्ट बोल सकते हैं एम्पैथी बोल सकते हैं पर्सन टू पर्सन टच बोल सकते हैं वो अपना हमको ओन करना है सो यू डेफिनेटली अगर आप थ्रेटनिंग आप ओवरटली सूट बूट पहनकर चले गए और वो बड़े साहब बन कर गए तो ठीक है यू माइट बी थ्रेटनिंग डोमिनेटिंग बट वो मैसेज नहीं जाएगा सो फॉर गेटिंग द मैसेज into the minds of people you have to match them at a certain level so you have to dress appropriately I didn't say you dress in a most histrionic way dress appropriately to the situation.
I think this is what I wanted to ask. Thank you.
Sir, any feedback from this Dawa Doa project that how far this has been effective and sustainable? If improvement has to be sustainable, then only it is considered to be improvement. Any
Yeah.
radical studies on this?
Yeah, it is working well. And it has also been opened at one place in Tamil Nadu also. So Gujarat model is going on. And Tamil Nadu at Irravadi also opened this project. Initially, there was a lot of resistance from the religious preachers, but now they are in tune with them. So people are seeking, attending actually both the places. So they are seeking help also from the clinic, and they are also doing their religious rituals at the Majar also. So it's kind of helping them a lot.
In fact, sir, if I may add, in our clinical practice, we get regularly patients from Ojhas, from Maulvis, from these people who are at the Mazars, and they said that ठीक है अभी भूत प्रेत मैंने कर दिया है अब बीमारी है अब वो डॉक्टर साहब से मिल लीजिए so they we regularly get referrals direct referrals from faith healers.
Sir, there is no second opinion. The system is been working since ages. And the more people have started realizing it's a medical model or psychomedical model, the medicine is coming out in this model. My only concern was that, my only curiosity was that do we have any uh, authentic information so far the follow-up and that how many cases out of 100, what is the percentage of recovery if it is there, so what type of disease they have recovered. Obviously the neurotics hysterical problem would be improved faster than other conditions. These things are there, but I just statistics wise, do we have any follow-up study on this? My concern was that only.
I think published literature नहीं होगा, but clinic का अपना जो data है, I mean thousands of patients they have attended with all variety of psychiatric disorders.
Fine, sir. Thank you very much.
So if there are no more questions, we can thank Dr. Vivek Agrawal, sir.
One question.
Yeah.
One question. Myself, Shonali, I have come from Calcutta. I am working as clinical psychologist in community sector in district mental health program since 2008. Hence, I have a lot of experience dealing with children in community level. Sir, thank you for your presentation. I'm adding one thing. Beside, you have mentioned Asha Anganwadi teachers. In West Bengal, there is a one post lady counselor or Onnesha counselor who specifically deal teenage and adolescent crises in all block hospitals. And that's why we cater lots of children and adolescents cases under community health care system. And as Professor Dr. Jaiji is asking, uh, we have some, we mostly get depression, anxiety, somatoform cases in the community level, especially conversion disorder mostly. And also, we are also getting cases from OJAs and faith healers too. Thank you, sir.
So I think we can now thank Dr. Vivek Agrawal, sir. Actually, sir is my senior from MBBS. So I'm very comfortable. Zaidi sir is my senior from CIP. And many friends are there. So I am in a very comfortable place. Thank you, sir, for inviting us here. Thank you.
Thank you, Dr. Agarwal, and thank you, Dr. Siddiqui. I would now like to request Professor S.Z. Zedi, sir, to please felicitate Dr. Agarwal and Dr. Siddiqui. I would also like to request Zedi, sir, to please felicitate Tripathi, sir, and Dr. Kirmani, sir. Can we have a huge round of applause, please? Our next session for the day is going to happen in the online mode. It is the challenges before community mental health service providers, an international perspective. It will be led by Dr. Vinay Lakra, who has been a trailblazer in psychiatry, clinical governance, patient safety, and medical education. Dr. Lakra is a Melbourne-based psychiatrist and has made history as the first Indian origin president of the Royal Australian and New Zealand College of Psychiatrists. He assumed office in May 2022 for a 2-year term. Originally from India, Dr. Lakra graduated from JN Medical College in 1999 and earned his MD in psychiatry from the Central Institute of Psychiatry in 2002. He is actively involved in mentoring junior doctors and he continues clinical practice, including electroconvulsive therapy, ECT. Dr. Lakra is also working towards streamlining assessment pathways for overseas psychiatrists in Australia, including a proposed collaboration with an Indian medical body. He highlights the Indian Australian community's collective culture as an asset in addressing mental health challenges. Please join me in welcoming Dr. Vinay Lakra. The session will be chaired by Dr. Pragyan Dangwal, ma'am. Dr. Dangwal has over 20. Oh, okay. Over to Dr. Lakra.
Look, thank you so much. And I hope you can hear me clearly.
Yes,
Yes,
sir.
no, yes.
Yes, yes.
You can, okay. Okay. Thank you so much, Dr. Jazzy. It is a pleasure to join you. So, and I'm sorry I can't make it in person, but I am in Delhi. So I'm not too far away from all of you. Let me share my screen. Okay, so you can see the presentation, I assume, because I can't see anything on my screen for myself. About challenges before the community mental health service providers. And essentially, what I'll talk about is a universal issue, not just in Australia or in other high income countries, but also in low and middle income countries. And I've got around half an hour to do this. Many of you would have seen this slide. This is fairly commonly seen on the social media about the issues of discrimination. And we know that a lot of people who experience mental health problems in their life, uh, it's driven by all these issues of inequity and discrimination. And if you really look at it, I think we need to develop solutions which allow people to be able to participate into things in an equitable manner. So the extreme right and where that barrier is removed is a good solution. All other solutions are not very effective. So I think we need to look at and identify where are the barriers so that people can do things better. Now, this is some of the Australian data, but it's not vastly different. One in five, we talk about one in five, one in four people who have experienced some sort of mental health problem or a mental disorder in the previous 12 months. 5% of the population is estimated to have some more severe mental illness, schizophrenia, bipolar disorder, severe depression, and things like that. Anxiety disorders are a lot more common, and then mental health and substance use, and they are a high contributor to the non-fatal burden of disease. And that this is true basically in all countries. And again, there is some Australian data from the national surveys, and they found that 2 in 5 had experienced a mental disorder at some time in their life. Now, the problem with many of these surveys is that they are based on information gathered, and so they come with all sorts of biases. But I think essentially what we're saying is that around 20% of the people in the world have some sort of mental health problem, which is actually quite a significant challenge. Again, this is some work in Australia, but has been replicated in many other parts of the world, that those who are poor, they have high mental health problems.
Dr. Lakra,
Yes.
sir, can you please put your
Yeah,
the
yeah, I can
PPT
hear
on
you.
the slide?
What do you want me to do?
Sir, can you please change
Wait a
the slide?
minute. Wait a minute. Wait a minute. I think there is some. So I will share my screen again. Share. Can you see it?
Yes, yes, sir, we can see it now.
Okay. Now, can you see the graph, the socioeconomic disadvantage?
Good morning, Lakra sir. Zaidi here.
Ah, sir.
How are you? Your slides is not changing, Dr. Lakra. It's a fix.
They're not changing.
Yes, not changing.
Oh, I am. They're changing on my side.
We are still on the first
Can I
slide.
send the slides to you?
Yes, please. Yes, please. If you could.
Okay. Is it possible that I send the slides to you
Right now you can
and
send
then
it.
you can run the
We can show.
slides? Give me a
Dr. Sajid will help us.
second and I will just. Yeah, yeah. I think I've sent it to you before. Um, See, despite everything, technology still sometimes gives us trouble. So, what email address do you want me to send it to?
Sir, the email
Maybe
address
they can just
is nsingh10
N N
nsingh
yes
10
10 yeah
at lko
LO
dot amity
dot AMITY
dot edu.
dot edu. Okay, just okay. I've sent it.
Okay, sir. Sir, you can continue and we'll put up the slideshow here.
Yeah, yeah. Okay, okay. No, it hasn't gone yet.
Uh, Dr. Lakra,
Yes,
sir, we have sent you
I
the
don't think it has gone yet. So
Sir, you must be having Zaidi sir side. You can share on the Zaidi sir side with access. Professor Zaidi.
I think there is some problem with my email. So it should
Sir,
go,
you
but
can
it's
share
not
on the
going.
WhatsApp number of Zaidi sir.
It's on my laptop. It's not on my. So I still have to somehow send it. Give me a second. Give me a second. I'll. And sing, no, it's not.
So you can also send it to Zedi sir's WhatsApp.
I'm trying to. I think it's not.
Dr. Lakra,
Yes.
you can continue with your presentation.
I'll try and share it again and see if it helps. I think. Let me just close all of my windows because I think that might be the reason why. I think it's gone now, so you should have received them.
All right, sir.
Have you received it?
Not yet, sir.
Yeah, it's gone. It's gone from my side. So
So due to some technical issue, we're not able to access it.
okay, I'll
Uh,
try again. This.
but you can continue with the presentation, sir.
Let me try the share the screen once again, and let's see if it works this time. Otherwise, I'll just continue with it.
All right, sir.
Okay. Okay. Now tell me if you can. You can see the slides, isn't it?
Yes, sir.
Can you see it? And is it moving?
So we can see the first slide.
It's not going to the next one.
No, sir.
Okay.
So
So there is a
can we switch it
problem.
to the slideshow mode?
Okay. Help me again. What mode do you want me to switch to?
So there's a, uh, a sign on the bottom right next to the Zoom bar.
Next to the Zoom bar.
At the bottom of the screen, sir.
I can see participants' chats, reactions, new share.
Sir, sir, if we can request you to continue with the presentation, we are intently listening into your address.
Yeah, yeah. No,
So
no,
you may
I get,
please
I get.
continue.
I think I understand that. I think we just
Thank you.
trying to see if we can. Okay, so I think so. Really, um, so so obviously, as I said, 20% of the world's population has got some problem. That's what all the surveys tell us. And then we also know that people who are socioeconomically disadvantaged, they have more mental health problems compared to those who are economically more advantaged. So, for example, there is Australian data that people who are the poorest, 1/5, 1 in 4 of them have a psychological problem, distress at a high or very high level, and that compares to around 1 in 20 for the people who are the richest 20% of the population. And that's a very reasonable gradient as well. So it's not like uh, uh, that it kind of correlates very well with income. And we also know that the social and economic problems, they increase the risk of mental disorders. Financial problems are associated with depression, suicide, drug dependence, and psychotic disorders. Now, I think one of the problems really we have is we talk about mental health, but really what we're talking about is two different issues. We're talking about mental health as it is defined by the World Health Organization. It's a state of well-being, and really it does not really capture psychiatry. It's the same thing as in when we talk about health. We really talk about things which are about keeping you healthy, and we don't talk about different illnesses. And I think that distinction is very clear in the rest of the health, but it's actually quite blurred in mental health. So when we talk about mental health, and if we did a survey and asked everybody who's in the audience, what does mental health mean to you? They'll talk about stress and stress related problems and all other things on one hand, and illnesses like depression, anxiety, schizophrenia, bipolar disorder on the other hand. So it's kind of all inclusive, and I think that is a fundamental problem for us. So on one end of the spectrum is social and emotional well-being, which is more about public mental health and what we're talking about today, including things like stress and how do you manage it and what happens at workplace and what happens in people's personal lives and how do you address issues around poverty and those things. And the other spectrum is psychiatric disorders, which is the illness spectrum. The problem we have is that we've got of ever expanding diagnostic categories. And so what we keep saying is, when DSM started, it was a small textbook, and now it is expanded into a big volume with ever expanding diagnostic categories without necessarily making treatments available for some of those problems. And so I think there is this growing influence of what is a disorder over what is normal emotion or what is a well-being issue. And then I think in all of that, what is the role of the community mental health? Okay, I think you're still there. Okay, suddenly my screen went blank. And so, what are the evidence, and what is what can we learn from the implementation science? I've got some beautiful slides. Unfortunately, you can't see it. So, I conceptualize this well-being and illness spectrum as two big areas with a degree of overlap. So, imagine there are two circles. One is social and emotional well-being, or what we call as social psychiatry, and the other one is mental illnesses and what we call as disorders of brain and mind, or clinical psychiatry. and and they kind of overlap a little bit. Obviously, there are people with psychiatric illnesses who've got social and emotional well-being problems, and there are people who develop social and emotional well-being problems and they go on to develop depression, anxiety disorders, and those kind of things. And so the challenge for us is how can we increase well-being, and which can help us reduce illnesses. So for example, in general health, if we address iodine deficiency through iodized salt, then we know that thyroid related problems, they decrease or they do not happen. And there are many other examples in general health. If we provide clean drinking water to people, then we know that diarrheal diseases, they decrease. So that's challenge for us. How can we increase well-being related initiatives, and that will have an impact on reducing some of those illnesses, not all of them. The evidence is actually quite clear. We have not been able to reduce the incidence of illnesses like severe depression, schizophrenia, and bipolar disorder. But yes, problems which are more milder in nature, they can be impacted by some of those initiatives. So what are community mental health service providers? I think there's a key issue for my talk. And it's a broad array of organizations. There are government organizations who run hospital and health service providers. They have inpatient services, community mental health services, and there are obviously non-governmental organizations as well. And again, they are array of mental health services in the community. And it varies by country, but essentially, yes, these are the two main sources of funding through the government and through non-government organizations. Then, of course, there are private services which are provided by individuals or organizations as well, which are outpatient type of services or hospital-based services. And so, essentially, when we talk about community mental health service providers, again, one of the fundamental problem is that we have a large group of organizations, and they're all doing all sorts of things. And sometimes it is very difficult to kind of work out who's doing what. Um, and so with that thing, some of the key challenges around that cohort is to find out what does a community so are you working with children and address childhood problems? Are you working with addressing poverty reduction? Are you working with people who have psychiatric illnesses and providing employment to them? I earlier this last year I attended SCAF, which is a Schizophrenia Research Foundation in Chennai, their conference. And one of the questions which came up was whether SCAF should expand the services it offers. So obviously it is about the work started around schizophrenia, but should they expand into other areas of mental health problems? And I think that's a fundamental problem with all of these community mental health service providers is what is it that they are doing? What is their identity? If you are running an organization, how do you define what is the scope of your organization? What is in scope for you and what is outside scope for you? The second major challenge for all of them is evidence and effectiveness. How do you know the thing you are doing? What is listening to the previous speaker and serve as one of those evidence issues is that placebo response is very high, and the difference between placebo and intervention is not quite significant. And then I think the other problem with this is that it is very difficult to demonstrate the exact benefit of prevention. So if you are running a suicide prevention program, unless you can demonstrate that it has led to reduction in suicide rates over a sustained period of time, it's very difficult to say whether that program is effective or whether it is not effective. So I think that is a fundamental problem with many of these community mental health organizations. Then there is duplication, as I've been talked about. Of course, many organizations are doing things, so they're not collaborating with each other. Sometimes, as a result of that, so they want to continue to do what they are doing and they don't want to work with other organizations. There are issues around sustainability and financial and otherwise. Does your workforce know what they are doing? Can they deliver some of those evidence-based psychosocial programs to the population they are serving? So I think all of that is actually quite relevant for all these organizations. And are we constantly really playing catch up, and why? Despite lot of things which we have done, certainly during COVID and since COVID, there is no clear evidence that actually things are getting better. And that is true in Australia, that is true in many other countries. And if things are not getting better, then we really need to look at all of these challenges I've talked about. That maybe there are opportunities and solutions through addressing some of these challenges in terms of why we are not getting better, why things are continuing to be the same. So really, I think talking again about the challenges and opportunities. One is, of course, the public mental health approaches. So what can we do to reduce prevalence of mental health problems and illnesses? And so some of the solutions are outside of health. So for example, when we talk about addressing poverty, addressing domestic violence, addressing loneliness, addressing some of the substance abuse related issues, they are not necessarily directly in control of mental health service providers. They are more of a support system. they are influenced by the government policy. And so how can we influence some of those government policies? And then the other major element is mental illnesses. So how do we keep people well? How do we make sure that we intervene early when we identify that there are people who have a chronic recurrent illness? How can we prevent outcomes? So again, as I talked about, really those two broad spectrums, what is the illness spectrum and what is the illness spectrum, and how can we work together? The other thing which is quite important and relevant in this is there are lots of models of care, and there are people have talked about staged model of care ranging from self-help resources and mental health services on the other hand. The problem with many of those models is that there is lack of clarity of who is doing what. And also we know that if you have too many choices, I was one of my friend was telling a beautiful story. So they noticed that if somebody came to buy a shoe in their shop and they said, okay, show me that shoe and show me that shoe, so they showed them two shoes. And then if the person said, oh, show me that third shoe as well, and if they brought the third shoe as well, then they found that uh, the sale was uh, there were less sales. Whereas if they said to the person, okay, these are the two you're seeing, which one do you want me to remove, before they brought the third shoe? So essentially they're constantly helping them make a choice out of the two choices. Then they found that their sales were higher. So I think choice is an interesting concept, but it also, when we have too many choices, it creates problem for us. What else can we do now? So of course we can talk about public mental health interventions. Sir was talking in the previous lecture about a range of things. I'm not going to go through them again, because we know that we cannot provide care to 20% of the world's population. There's one thing I want to drive really clearly through this is that when we talk about these surveys and 1 in 4 have a mental health problem and 1 in 5, there is no way we can provide care to 20% of world's population. So we have to find ways to help people learn and address issues, and also clearly demarcate what is an illness and what is a stress and well-being related spectrum and how we can help that. So we really need to invest in some of those public health approaches which prevents mental health problems. So same thing, going back to iodine and thyroid, it's much easier and cheaper to provide iodized salt to people than to continue to treat everybody who develops thyroid problems. So I think we need to do the same thing as well. That if we're going to address this issue, then we need to address some of those things we've talked about: poverty, resilience building, distress tolerance, of issues. We really need to address that. And I think those challenges lie outside of mental health sector. They don't necessarily lie with us. But we need to provide leadership and collaborate with those services. And then I think the other thing we really need to do and heavily invest in is providing psychosocial treatments for people with mild to moderate problems, not necessarily through professionals, but through people other than health professionals. I remember when I used to study community medicine, we used to talk about a village health guide. A village health guide was supposed to provide some basic interventions for a few things. And I think it's a similar thing which needs to happen, that how can we use people, the resource we have. People is a resource we have, especially in low and middle income countries. How can we use that resource to address some of those problems? As we talked about, when somebody introduced me, they talked about my work around our collective society and how we can do that. What else we can do? Especially for people who have a psychiatric illness, I think we need to treat people and retain them in treatment, whatever their model of care. We need to address their physical health issues. We need to address their modifiable factors, as in smoking, alcohol, obesity. We need to prevent homelessness and a range of things. So I don't want to talk more about that because that's a completely separate topic about treating people who have a psychiatric illness. We need to do the same thing what we do for people who have other chronic diseases. You have hypertension, you have diabetes. We don't treat you episodically. We say that you need to take this treatment over a longer term. And so if you've got schizophrenia, bipolar disorder, severe depression, we need to focus on some of those things. last few things. So really, I think the other thing which is a couple of slides, and then I'll finish, and then we can have some questions. Is that provision of care in the hospital is the most expensive way to provide care to people, whereas provision of care in the community is cheaper than providing care in the hospital, or providing care to people in their own homes is even more cheaper, and investing in preventative or lifestyle measures even more cheaper. So there is this concept, what is called as Moore's law for healthcare. uh, Ireland have actually adopted that, and they talk about staying left and shifting left. So staying left means using technology to keep people well in their homes, especially with chronic conditions, to self-manage. So if you have got diabetes, you can self-manage your blood sugar, you can check your blood sugar, you can adjust your dose, you can monitor over a period of time. Can we do the same thing for people who have depression? Can you monitor your mood every day, and that can help you better understand what's driving your mood? Can you use technology or apps to actually understand your mood? And stay shifting left means finding technologies that help people move as quickly as possible from acute settings into a community setting, and finally to a home setting. So hospital-based care is a very expensive way of doing things, whereas providing care into the community, and more so investing in primary prevention, is a more effective way of helping people. Lastly, we have to use digital resources and digital tools. Now we know that there are lots of our countries where they have national digital mental health frameworks. We continually working on that. The pandemic was a good source of development in that technology, so we need to do that. You would be surprised that despite the fact that over many years, many decades now, we've talked about access to clean drinking water for everybody in the world. As of today, and I'm not an expert in it, but I just did a Google search. As of today, 74% of the world's population has access to clean drinking water. But did you know that 68% of the population has access to internet? So it has taken us decades and decades to provide clean drinking water to 74% of the population. But it's only taken us a few years for 68% of the population for internet. And I think that's the potential we need to use. How can we use digital resources to help our cause and contribute to it? Knowing that, of course, digital tools come with their own problems as well, as we are seeing in younger people as well. So in summary, really, I think we need to really address the confusion. I think we can't continue to just talk about mental health. I think we need to separate the issues of well-being and illness, because if we address that confusion and separate that, then we can focus better on the interventions we want to do. We need to continue to develop evidence base for some of our interventions. We need to work together with other people rather than be competitive with them, because essentially many of these issues, they influence a wide range of things. We really need to address the social issues. Poverty is one of them, and I think there is a bucket load of data and research around when I think previously as well, sir was talking about providing financial assistance to some women and how their outcomes were improved. So poverty is a key social driver for lots of mental health problems. uh, it's not necessarily it is a driver for a lot of depression and anxiety as well. And it might not be a key driver for people with schizophrenia and bipolar disorder, but it actually is a perpetuating factor for those illnesses as well. So poverty actually impacts the whole spectrum of mental health, what we talk about. So I think we need to do that. We all know, we've been taught for a long time, that prevention is better than cure. And so I think we need to continue to find ways to use prevention strategies rather than just investing in treating problems. And lastly, we must wisely use technology. Um, as I said, it's not possible for us to treat 20% of the world's population. And so we have to develop resources so that people can self-manage things, they can identify things themselves, and there's an array of things available to them in managing some of those things. And thank you again, and my apologies for the slides confusion. What we'll do is I've sent the slides to sir, and hopefully we can share them with all the participants. They are not copyright protected. You can feel free to use them. Um, but yeah, thank you very much.
Thank you so much, Dr. Lakra. And at the very onset, I would like to say that I am highly privileged and it is an honor to be here with you and listen to your discourse. I will now open the session for the questions. If you have any questions, audience, for Professor Lakra. All through your address, sir, there were very important things that you came up with and told us, and that comes out from the sheer experience of working at the community level. Your expertise in this area has helped us understand the issues that are there regarding mental health services, and how we need to look at mental health, providing mental health at the community level. You very well emphasized upon we are still do not understand what exactly mental health is, and that is and how we perceive it and how differently we perceive it across different areas, places. And when you're giving a discourse for internationally, when we look at it, that confusion still exists, where mental well-being and mental illness are at times viewed same, but they need to be looked at differently, because from where we can work on interventions much better. You also emphasized on self-management, which is a very important, becomes a very important part of community healthcare, because at the community level, not everybody has access to experts, mental health experts especially. And that is where Professor Lakra said that we need also to collaborate with the non-professionals. So when we are talking about community health, we often include non-professionals, because then we are addressing lot many people for whom we still, there is a great lack of specialists to deal with that. So we need to collaborate with others when it comes to community mental health. Provision of care, as I said, that was expensive, when and the expenses, especially in poor countries, when we need to bring them down, we need to address mental health issues at the family level, at the primary caregiver level, and that is where we will perhaps decrease the number of illnesses and issues which are propping up today. One very important and significant aspect that Professor said was that we still are dealing with stress, anxiety, and depression more at the community level, and still ignoring many of the other grave issues and disorders which exist there. We cannot separate mental well-being and mental illness. But yes, we need to focus more on mental well-being. Am I right, sir? If that is what you wanted us all to make note of.
Oh, thank you, ma'am. You've summarized it very well. Probably better than what I could say.
Not at all, sir. That is where we come to the end of this session. Um, if there are no questions, um, we will end the session here, and I would request Professor Zedi also to address. Thank you, sir, Professor Lakra, for bearing with us also with the technical glitches at our end. But I guess it was more wonderful to hear you speak and us concentrating more on how what you spoke, rather than just looking at the PPT. So in all, it ended well. Thank you so much.
There's always an opportunity in everything we do, isn't it? So I'm I'm happy with that. Thank you so much.
Uh, Thank you, Dr. Lakra. My personal thanks to you, and on behalf of the MIT University and MIT Universe, I put on record our gratitude for your very, very scholastic presentation in spite of your very busy schedule. You always reply very promptly to my requests, and I hope that we will maintain the same relations future too. And when I came to know that you are traveling to India, and I was really feeling bad about it, that the date could have been matched with your arrival to India, and we missed you just for a day. So next time when you please come to India, please let me know in advance so that I can invite you for and to make the best use of your expertise and share with your our students. Thank you very much. And in spite of your technical glitches, which is always expected, and you really justified with your assignment. Thank you very much.
Thank you, sir. Thank you. Look forward to continuing our collaboration. And yes, absolutely. Next time, I will. I think I just mismanaged my schedule by a day. If I had arrived a day earlier and didn't have the commitment here, I would have been. It would have been actually much better to be there in person. But next time, thank you so much.
Kakra was here till yesterday in India, but now it's just gone.
A heartfelt thank you, Dr. Vinay Lakra, sir, for an enriching and insightful session. I would now like to request Professor Jena, sir, to please felicitate Dr. Pragyan Dangwal, ma'am. Thank you, everyone. We will now be proceeding for a short tea break, after which scientific sessions will take place. The venues of the scientific sessions are the auditorium, conference hall, multipurpose hall, seminar hall, and PG lab in AB6. Thank you.
University, Lucknow. She has been dedicated to the field of academia since 11 plus years. Her philosophy of life, Iswadharm, is the foundation of blissful life. So, so moving on, it's our pleasure to invite our distinguished presenters to share their expertise and insights with us. We have a stellar lineup of speakers who will delve into the latest developments, trends, and innovations in the field of psychology. I look forward to insightful discussions and invaluable collaborations. Let's work together to make a lasting impact on public health. But before moving on, I'll clarify the audience the standardized instructions for the presentation. That is, the participants will have a total of 8 minutes to present. This will be followed by queries and discussions of the respective paperwork. A bell would be ring after the lapse of 7 minutes, and you are requested to wind up in the next 1 minute. So moving on, let us give a warm welcome to our first presenter, that is Shagun Katoch, with the paper title Mapping Biopsychosocial Pathways in Premenstrual Syndrome, a systematic review of influences and impacts. Shagun Katoch, can we have you on the stage, please? Our next presenter is Ms. Prasanta Kumar Sethi, who will be connecting with us online. Our next presenter is Ms. Shreya Jana, who will be speaking on a systematic inquiry into obsessive compulsive disorder, revisiting the clinical picture. Ms. Shreya Jana. Yes, can we have Shivani Alina Barwa, who will be presenting on redefining masculinity through the voices of gay and bisexual men in India? What Shivani again? I just it's here. Can I call Hafsa Khan? Hafsa Khan.
Afternoon. Okay, so next. So my topic is exploration study on the shifting paradigms of masculinity in modern India. And I'll start with an opening statement on back in 1975, there came a movie, very famous movie by Amitabh Bachchan called Diwar. And it portrayed the famous angry young man image called Vijay, a man who didn't bend, who didn't break, and that didn't definitely cry. So strength for him was about fighting alone and carrying the weight of the world on his shoulders. And let's be honest, that movie gave us some most intense one-liners also. So now fast forward to 2023, and we have Rocky Rani Ki Prem Kahani, where enters the character Rocky, who is shown as someone who is a typical macho man. But over the course of the movie, we see him as expressing emotions and even crying. So this isn't just about Bollywood makeover, but it also reflects on the bigger shift in the Indian masculinity. Men today are navigating a space where strength isn't just about muscles or anger. It's about expressing vulnerability and breaking existential traditional gender norms. So my question is that how is masculinity evolving in modern India, and how are Indian men balancing tradition with changing gender norms? So let's talk about masculinity, how that is depicted in the definitions as we call that. It's called as a set of attributes or behaviors or roles that are generally associated with men and boys, varying across societies and contexts. We can see that in physical form, we see that they have endurance and strength, and behaviors, we see them in the roles of leadership. And in social form, we can see them as providers or protectors, and especially in mentor roles. But now we have to take some things in consideration, where that we can say that masculinity is something that exists on a spectrum. It varies across cultures, and the concept is dynamic and evolving. There have been researches on the masculinity, but which talks about dynamic transformations, where they are reshaping the traditional gender roles and embracing egalitarian views. They're also talking about redefining domestic roles where they challenge hegemonic ideals, and also talking about emotional vulnerability where openness to emotional expression is there. However, the research gap that comes in is that there is no subjective experiences covered especially in Indian context, and also the socialization or the media or the cultural beliefs that are contributing to this transformation. So this research is aiming to center those voices of Indian men. Next, I'm talking about the theoretical framework where my research is rooted in the Connell's theory of hegemonic masculinity, which is talking about, which is giving the lens to it from a form of dominant forms of masculinity, which is associated with strength, heterosexuality, and power. Also, how social constructivism is playing into this is masculinity is not a fixed entity, but rather a product of social interactions. So my methodology is I started with a qualitative research, and it's an exploratory study with a constructivist paradigm. It was conducted on 11 cisgender males from 18 to 60 years of age range from diverse geographical locations. The data collection was through purposive sampling and conducted through semi-structured interviews. Data analysis was through Brown and class thematic analysis, and ethical considerations were taken into consideration about confidentiality, informed consent. So the results that came, themes that emerged were three main themes that were metamorphosis of manhood, the looking glass society, and the bridge between worlds. So talking about the first theme, that was the metamorphosis of manhood. The name was inspired by Franz Kafka's Metamorphosis, which was talking about transformation, and it's also talking about breaking the mold and redefining strength and stability. So the key transformations that happened were shift towards the emotional intelligence and vulnerability, and a collaborative strength was coming in, where we can see that in a support from the participant AD statement, it's not showing the muscles, it's showing your effectiveness and efficiency, how effective you are in a group. Then we are talking about economic evolution, where from the sole providers, they became as a shared responsibility, and also the gender fluidity. As supported by participant Wyatt's statement, masculinity and femininity can coexist together. We can think it as both the things can coexist together in males and even in females. Next theme was the looking glass society. It's a famous concept given by Cooley of looking glass self. So this theme was name was derived from that theme. How masculine identity is shaped through the social reflection and cultural mirrors, and highlighting the dynamic interplay between individual identity and societal expectations. So we are talking about strength in emotion and the courage to be vulnerable. So redefining strength, and where we are talking about vulnerability viewed as a courage rather than a weakness, and also expressing weaker emotions as we call it. So as supported by this participant VN statement, that I think a lot has changed with regards to how much you can express your emotions as a man, especially weaker emotions that people say like sadness or grief or crying. Next, vulnerability is also acting as a tool to form deeper connections and building connections. So, and also in team building. As participant AD highlighted that masculinity could be defined better if we can convert a group into a team. It's not by force, it's by wisdom, it's by intellect. The last theme that emerged was the bridge between worlds, which is talking about the shared responsibility that came up. It's talking about collaborative approach between partnership model in financial responsibilities, as supported by the statement by participant AD that both are earning, wife and husband both are earning, both are sharing the expenses, sharing the equal responsibility. Also the emotional support and financial provisions, and also in the shared domestic duties, as supported by the statement by participant V, and that nowadays I see that even the male members are going to the kitchen. If his spouse is working somewhere, even for preparing the lunch or dinner, the husband is helping his spouse. So after this, we come to the conclusion that the research is defining that gender is on a spectrum of change and it's dynamic in nature, which is day by day evolving. And there's a balanced integration between the traditional values as well as the modern perspectives that are coming in different contexts at multi-dimensional impact. So this research reveals a fundamental transformation in how masculinity is understood and experienced in contemporary society. There is an evolution from traditional stereotypes to inclusive expressions, integration of emotional vulnerability with strength, and shift towards shared responsibility and collaborative relationships and active construction of gender identity through social interactions. These insights also support the positive changes in masculine identity while respecting the complex balance between tradition and progress in contemporary society. So limitations and future directions would be that since the sample size is very less, it's covering the urban setting, we can have conduct the research on a rural perspective, including that. So thank you.
First of all, the topic that you have taken, you have chosen is very good, very nowadays it's actually needed. And one thing that we would like to know, or I would like to know that how you have collected the data.
So we conducted the semi-structured interviews through online as well as offline.
Can you tell me what type of items that you have used in your semi-structured?
So it was based on simple semi-structured interview-based questions where
questions which you have framed for your interview. From where you take those questions? What inspired you to draw those questions in your personality?
So it was based on exploring the main one was basically emotional aspects. So I went through some scales as well as also we got it from experts. We checked the interview schedule and then only we administered the interview schedule.
Thank you, Afza Khan. Our next presenter, Akansha Arora, with the paper title Cognitive Function, Emotion Regulation, and Social Support in Self-Care of Individuals with Hypertension.
So good afternoon, everybody. My name is Akanksha Arora, and I'm a PsyD clinical psychology scholar from IVAS, and I will be presenting my topic on cognitive function, emotion regulation, and self-care in individuals with hypertension under the guidance of Dr. Sonia Pawar, Dr. Deepika Srivastav, and Dr. S.K. Agarwal. So according to the World Health Organization 2023, hypertension affects approximately 1.28 billion individuals worldwide, 2/3 out of which effective come from low to middle class income countries. Hypertension is a leading cause of premature deaths globally, and out of these, 46% of the individuals don't even know, are not even aware that they have hypertension. Only 42% of them get diagnosed with hypertension and get treated. As per terms of India, it is estimated only 1 in 4 that 1 in 4 individuals have hypertension, but only 10% of them have their blood pressure under control. So hypertension, which is also regarded as one of the silent killers, impacts both physical and psychological health. And long-term hypertension leads to reduce quality of life and causes emotional distress, which can also lead the individual to developing anxiety and depression further on. Hence, comprehensive care should go beyond medication and should involve self-care practices. Now, self-care would include having a good diet, exercising regularly, regular monitoring, stress management, medication adherence, and others, right? So there are several factors that influence an ability of an individual to engage in hypertension self-care, namely cognitive function, emotion regulation, and social support. Now, there are so many studies which have examined these factors independently, separately, that how these factors influence the hypertension self-care. But now there's a gap where limited researchers have examined the integrated effect of these three variables together, that how these three variables like cognitive function, emotion regulation, and social support, how these three together impact hypertension self-care, for which we need a comprehensive approach for understanding the combined effects of these three factors, which is important for developing interventions that can address both the medical and psychological or social aspects of hypertension management. So the aim for the current study was to explore the role of cognitive function, emotion regulation, and social support in self-care among individuals with hypertension, for which the objectives were first to explore the relationship between cognitive function, emotion regulation, and social support among individuals with hypertension, and to explore the relationship of these three with self-care among individuals with hypertension. The hypotheses were that there would be a significant relationship between cognitive function, emotion regulation, and social support among individuals with hypertension, and a significant relationship between the three factors in self-care among individuals with hypertension. This study employed a single group cross-sectional research design with 31 participants aged 30 to 60 years of age, both genders recruited via purposive sampling. So the inclusion criteria involved recruiting participants without any history or current diagnosis of any psychiatric or physical conditions, who were proficient both in Hindi and English and provided informed consent. The measures used for this study were PGI memory scale, trail making test, both A and B, emotion regulation questionnaire, Duke UNC functional social support questionnaire, and self-care inventory. These are the details of the measures, and the permission to access these measures were achieved from the respective authors. So now patients were recruited by the senior consultant of the cardiology department from a private multi-speciality hospital in Noida, Uttar Pradesh, after meeting the inclusion criteria. Individuals who then provided the informed consent were assessed via both self-report and clinician-rated measures. The statistics used for analyzing the data were used by SPSS version 28, where descriptive and inferential statistics were analyzed and correlation and regression analysis were done. The table 1 shows us the social demographic characteristics of the participants, where N is the sample size, percentage is the percentage of participants, M is mean, and SG is standard deviation. Coming on to table 2 is the Pearson's correlation matrix for PGI, MS, TMT, A and B, functional social support, emotion regulation, and self-care, where we can see memory and attention are both significantly correlated with executive functioning, functional social support, and self-care, with attention being significantly related to cognitive appraisal as well. Executive functioning is significantly correlated with memory, attention, and functional social support, self-care maintenance, sorry. Cognitive appraisal is significantly related with functional social support, and emotional suppression is negatively correlated with functional social support and self-care maintenance. And lastly, all the domains of the self-care, which is maintenance, monitoring, and management, are related with each other. Moving on to the regression analysis, we can see that functional social support significantly predicts memory, cognitive appraisal, and the domains of self-care. Emotion suppression negatively predicts self-care domains, while PGI memory significantly and positively predicts self-care. Attention, which is measured by TMT-A, significantly predicts memory, cognitive appraisal, functional social support, and all the domains of self-care, while executive functioning measured by TMT-B significantly predicts self-care maintenance and memory. These are the results summary. Coming on to the discussion, we can say that higher attention leads to better memory, which further leads to higher cognitive flexibility and higher perceived social support. Together, higher attention, higher executive functioning, better memory, and cognitive appraisal lead to better self-care routines. Emotional suppression is linked with reduced functional social support and reduced self-care maintenance. And lastly, there's a bidirectional relationship between functional social support and self-care. Conclusion: cognitive function, emotion regulation, and social support, these three work together to influence hypertension management by affecting the adherence, the stress coping of the individuals, and the overall self-care, which highlights the need for integrated medical and psychological approaches for both optimal control and long-term health care. Limitation of the current study were that the generalizability of the findings were limited due to the restricted demographic diversity, and the participant recruitment faced some challenges due to the exclusion of individuals with comorbidities. So we included just hypertension, individuals with hypertension. And these are my references. Thank you. Any questions or feedback? So for now, it's the study is still going. Right now, I employed 31 participants. Not just one-time encounter with the patients.
And you repeat the last 3 lines of conclusion once again.
Yeah, okay. So we can conclude that all the 3 factors which we have studied, basically cognitive function, emotion regulation, and social support, they work together as a team in hypertension management because they affect the individual stress coping, adherence, and the self-care management and the self-care routines by which individuals can manage their hypertension, which highlights the need for applying both the psychological and medical approaches for long-term healthcare, optimal growth and long-term health.
These 3 functions because are all functions together.
They are linked, yeah.
If there is any depression in any of the functions because of hypertension, one may lead to some conclusion. But what special eye-catching information you are sharing? Is it completed thesis or you are still working?
Still working.
Still working on it.
Sir, but one thing I would like to say that while I was measuring emotion regulation, as per se, so the way we perceive that emotion regulation is also a part, like it's also very much significantly related with all other factors like being cognitively online and being emotionally well regulated and having a good social support will be a significant predictor for managing everything perfectly. But what I found is it's not very, the cognitive appraisal wasn't too linked with both other factors, cognitive function and the social support. So it was a little.
Hello, thank you for the invitation. How many patients you are going to recruit in your study further?
So some sample size estimation per se requires us to do 77 patients. Yes, at least 77. 31.
This is your report, not a side report, okay? So whenever you present your data in any conference or write a paper or a publication, do mention the okay? And what you at the time of your PhD biology, so that is your original. Okay, thank you.
Thank you. Thank you.
Any feedback? No? No question. I'm going to ask one thing like, in any of these studies, have you mentioned the major definition of all theory? that we are taking
No, not for this presentation. Because of the time constraint, I wanted to focus more on the findings of the basis on which I was studying and the findings. So that is why specifically I didn't involve. But I will definitely include it. Thank you.
Thank you, Ms. Akansha, for that thought-provoking presentation. Up next, I would like to call upon Shivani Aline Barwa, who will be presenting on redefining masculinity through the voices of gay and bisexual men in India.
Hello, good morning, good afternoon, everybody. My name is Shivani Aline Barba, and I am from Christ deemed to be University, Delhi NCR campus. I am currently pursuing a master's in counseling psychology, and I'm in my last year of it. And under the guidance of Dr. Swati Pathak, I am here to present a paper on Beyond Boundaries, Redefining Masculinity Through the Voices of Gay and Bisexual Men in India. So, going on to the concepts that I have used for this particular paper are these three concepts that I've used. First is masculinity. One of my college mates have already talked about masculinity in detail, that it is a socially constructed concept often linked to strength, dominance. It also depicts behaviors like restrained behaviors and traditionally reinforced by culture, religion, and family. Going forward, the second concept that I've used is gay and bisexual men. These are individuals who identify as male and are romantically or sexually attracted to the same gender, gay, or both the genders, that is bisexual. The third concept that I have used is intersectionality, although it is not explicitly mentioned in the paper, but a lot of aspects of intersectionality has been used in it. So the overlapping effects of race, ethnicity, class, and sexual orientation on identity and experiences, and how this sexual orientation shapes and constructs the further building and the dynamic concepts of identity formation in a gay man or in a bisexual man. So moving forward, this is done in an Indian context, setting is the Indian context, and traditional masculinity in India, as we all know, is shaped by religion, family, and cultural expectations. And because of this, the gay and bisexual spectrum of the LGBTQ population often experience internal conflicts as they navigate their identities within a predominantly heteronormative society. It is difficult for them to navigate through it or as basic as even exist in this heteronormative society. So this study seeks to explore how these perspectives on masculinity are evolving, influenced by globalization, activism, and media representation. Moving forward is the literature review that I've done in this study. First is the masculine ideals and self-image in gay men, social identity and perception of homosexuality, hypermasculinity and homophobia, and issues in bisexual men's lives. So based on these, all of these are the researches done in a Western context. So based on this, the research gap that comes out is that most of the studies on masculinity focuses on Western context, leaving a gap in understanding Indian LGBTQ plus experiences. Intersectionality, like I mentioned, it is not explicitly used as a theory, but some aspects of this theory is present in it. So it is still a little underexplored. So, internal pressures within the LGBTQ plus society is also talked about in this particular research paper. And there is, in the literature review, I also noticed that the relationship between masculinity and sexual orientation is also left unexplored. So my paper also puts a little, not complete, but a little light on that aspect as well. Moving on to the theoretical framework, Connell's theory of hegemonic masculinity is used that explains how dominant male traits are maintained in society and how they influence the LGBTQ plus identities and how are they further shaping the identity formation. And intersectionality, like I said, some aspects of them are used like gender, sexuality, class, and religion, and how all of these interact among themselves to shape experiences of masculinity in this particular section of the LGBTQ plus community. The research questions that are asked is, how do gay and bisexual men in India define and experience masculinity? What societal and cultural factors shape their perceptions of masculinity? What role does LGBTQ plus advocacy plays in redefining masculinity in India? Moving on to the methodology of the research. This research design is exploratory, qualitative research, and it is done within the constructivist paradigm. The participants in total are 6 participants. Among them, there are 4 gay and 2 bisexual men, aged between 21 to 33 years, from different socioeconomic backgrounds. Data collection was done in a semi-structured way based on interviews. There were 3 written interviews done and 3 oral interviews taken. And further transcription and translation of the interviews were done. And data analysis is done according to thematic analysis given by Braun and Clark. Ethical considerations while taking into these interviews were considered as an informed consent, anonymity, and confidentiality maintained. This year I actually struggled a little because the information that were provided by the participants were very sensitive. So they were only ready to give the interview if I had to provide them proper written informed consent with their sign on it. So that is where the procedure got a little lengthy for me because of the availability of them also. Moving on to the results, the themes and the sub-themes. So while I was interviewing while I interviewed 6 participants for this particular study, a lot of themes came into light, but the overarching themes are these 3 themes. First is the burden of tradition. Second is breaking the mold. And third is redefining strength. So these are the 3 overarching themes that came into light after I completed the interview and the transcription and when I sat for data analysis. So moving on to the first theme, the burden of tradition, societal expectations, and masculine identity struggles. This is under this major theme. These were the sub-themes that came into light, which is the interviewee talked about the traditional masculinity in India and social and cultural and familial expectations, cultural and religious influence, personal struggles, masculinity and homosexual identity, pressures outside as well as within LGBTQ plus spaces, and how cultural expectations affected the conformity within these within this environment. So this was the first theme, overarching theme that came into light. The second is breaking the mold, the evolution of masculinity and the power of intersectionality. This is where, not like I mentioned, like implicit, there's no explicit mention of intersectionality, but a lot of aspects of it are used. Evolution of masculine characteristics, media representations, gender fluidity and expanding masculinity definition, navigating personal and societal expectations, and influence of age, religion, socioeconomic status on masculinity was also expressed in all the 6 interviews that I had taken. The last theme is redefining strength, LGBTQ advocacy, resistance, and the future of masculinity. Under this, the themes, sub-themes that were covered and which were talked about on repeated terms were resilience and resistance, LGBTQ plus communities' role in reshaping masculinity, how what is their vision for an inclusive future and what do they expect from the society and within their community as well, masculinity within LGBTQ plus communities, and body image and hypermasculinity outside and within the LGBTQ plus spaces. So based on this, the discussion that I have to give is something, it's like in a continuum of how initially masculinity was seen in the society, both in the heteronormative and the homonormative, as I have to say, community, and how it has shaped through all these years and what it is now. So initially it was seen as a very stoic, restrained, traditional aspect of human race, and the entire concept of कि मर्द को रोना नहीं आता, मर्द रोते नहीं हैं. From that to the community itself and the people within the community, men supporting each other, that it is all right to cry, it is okay. Crying is a strong emotion. So I can say that this to shape the society and how we see it, both the heteronormative and the homonormative society. And intersectionality further influences masculine identity, highlighting ongoing struggle between self-acceptance and social expectations. And this was very interesting that in different SES, the thought process of the interviewee was very different. And I got very creative and very informative and very diverse answers. So this one aspect of intersectionality shaped the way the themes were formed. Moving on to the limitations, small sample size was there. There were only 6 participants, which to some extent limited generalizability. Self-reported data was also there. The interviews were a little subjective. Everybody had different opinions to give. So it sort of included a bias also as to how one was viewing the society. It was very urban centric, so it was not able to fully represent rural LGBTQ plus experiences. The conclusion is that masculinity among gay and bisexual men in India is evolving, like I mentioned, but it is still deep-rooted, and the societal expectations and internal conflict remain barriers to full self-expression. LGBTQ plus advocacy and the importance of it has also been highlighted in this particular study, and how this would help in shaping a better future for both the communities, both heteronormative and homonormative. Future implications is that apart from just the gay and bisexual men, I think this study could also further inculcate the other aspects and the other umbrella terms of this entire community, and policy interventions to promote gender inclusivity, further exploration of hypermasculinity pressures within LGBTQ plus spaces can also be added to this. These are the references. Thank you so much.
Which sampling technique you have used?
So the sampling technique that I had used is purposive sampling.
Purposive sampling. You take some type of data to use purposive sampling.
Actually, I had to focus on this particular gay and bisexual men for this particular study. So hence I went forward with this. Yeah.
How many persons you have got in your society that they have the LGBTQ or gay type of thing?
So if I talk about society, I mean, for my definition of society, it was basically the college that I study in, and then their friends also. So hence, in that context of society, I actually used this topic and I used this method of sampling.
Okay, but you told that there is a stigma to identify the people like this problem. So, if everybody is coming to you and saying that I am against,
Actually, no. That is where the I absolutely agree, sir. Actually, this is where, like I mentioned, a little bit of a problem arose because in my context, since I am not in a very huge network with these people, I had to contact friends of friends of friends to go forward with this particular research. And approximately asking 50 people, 6 of them were ready to talk about this. So it was like a huge network that I had to go forward to. So yeah.
okay, that's why I am asking this question. That the purpose simply is not appropriate for this kind of study. Okay, I use it try some other separate technique like histobar method. You have about it? एक पर्सन को कहीं से आपने फाइंड आउट किया वो नो जैसे भी मिला उसके थ्रू आप जाते हैं तो इस तरह दिस इज द गुड थिंग ओके yes the researchers have been daring to take up this kind of topics for their research. I feel very well.
Thank you so much.
Thank you. Any other questions?
Thank you for this question. Before taking the interview, I was actually I'll be very honest, I was very confident about this particular topic since it also held a little personal touch to it. I had a personal touch to it. But while I was conducting the interview and after the interview was over and I sat down to do the transcription and the data analysis, a lot of I would say myths in my head got cleared. I used to think about it as a very black and white concept. Ki the people who are belonging to this community would be very much okay with, being out and proud, the term that we use. But while I was interviewing, a lot of additional issues came into light, such as family support. And because of the family support, they have this additional intrinsic desire to be financially independent, so that acts as a very huge motivator for them to, go forward with this intrinsic motivation of I have to be financially independent, otherwise I will not be able to get my family's acceptance. All of these things were mentioned in the interview, and concepts like additional concept that came into light was bullying through childhood, which was very sensitive to them. And a lot of reassurance was also done while taking the interview in order for the interview process to move freely. So, like I said, it cleared a lot of myths inside my head. And after taking the interview, this personally got a little heavy for me because I had so many diverse insights. Although all of the answers and all of the questions that I have asked were fit under this major themes that I have promoted, the type of struggles and the type of answers that I was getting were somewhat very unimaginable for me as well. So it also gives you the reality check of how the society is functioning. And you hear a lot of like colorful things that, okay, we are giving them advocacy, we are giving them uh, space to survive. But when I was hearing their stories, just it as basic as going into a cafe and not being stared at was a luxury to them. All of these things were mentioned in the interview process and while I was taking the interview. So all of these insights were gained. Yeah. Thank you. Thank you so much.
So I have two questions for you. One is the children that you mentioned right now. So can you think of any ways through which we can overcome as researchers these struggles while interviewing or while conducting researches with the community?
Uh, the answer to that is very basic because I also followed that. As researchers, we always are looking for some new concepts or some creative concepts that can be presented in front of the society. So while I was doing this research, I saw that I have to, like, I was interested in this research and I opted for it, that I have to present an entire paper on gay and bisexual men. So I was very much excited for it, but in amidst of all of this, I forgot that they are also human and we have to be comfortable with their setting as well. So what they asked was, I was like, I will give them a very comfortable environment. I will reassure them. I will do this. I will do that. All of these were very secondary things. The primary thing as a researcher, what we can give them is to treat them as another bunch of normal people. Like how normally we would take an interview of a heteronormative person, taking interview of a homonormative person in the same way and not pointing out things that, oh, you have gone through this experience. Oh, that is beautiful. Oh, that is nice. Overcompensation is something that they absolutely hated it because I went through with it in my first session and it got a little awkward. There was a lot of silence in my first interview. So I think something like that, they don't expect, they expect that we should not treat them as differently, but like treating them as another existing human being. Yeah.
So another thing that I wanted to ask you, since we are discussing a sensitive topic
Yeah.
here. So how many follow-ups did you have, or what kind of a rapport formation were you able to build while discussing these topics, while interviewing the individuals on this topic?
So first of all, when I got these contacts, while I was contacting them, I started with a text message that, hi, I'm this person and I am interested to take this interview. Are you willing for it? And when they agreed, I actually went up with a phone call. I followed up with a phone call and I asked them that thank you. And I told them that thank you for agreeing. I know it's tough for you, but giving them basic reassurance and basic validation. And the third thing that I did was before starting the interview, I took I would say 7 to 8 minutes to make them understand what the research is all about, debriefing them about it, that some questions might get sensitive for you. So if you don't want to answer them, it is absolutely understandable and fine by me. And there were interviewees that did not comply to some of the questions and they understood that it was all right to do so. So I think I gave, if I have to say, roughly 3 follow-ups. First was a text message, second was a phone call, and third was debriefing them and informing them about the framework of my research and what all am I expecting out of this. It's keeping them in the light. Yeah.
Just a suggestion, if you plan on following up with this research, taking the research and the topic further ahead, rapport formation, and since we are discussing an evolving topic, having contact with the same individuals, probably who are on the different study, will give us a lot more insight into the psyche of the individuals and how these topics are evolving through the project.
Yeah, definitely. I'll keep that in mind. Thank you so much.
Should I call it up?
Ma'am, it's okay, you can ask.
Yeah. Just one question. I mean, you said it was something personal to you. So did you experience any kind of social bias?
During the interview, I would say, yes, definitely, because I said that it is very personal to me. Belonging to this community, there was a lot of researcher bias involved when before and during the interview process. So when I was conducting the interview, I have already had the research, like interview schedule, that what are the questions that I have to ask. So in my mind, these questions were, the answers to these questions were already framed that, oh, this will have somewhat this type of an answer, this will have somewhat this type of an experience. And during the interview process also, when I was getting a different answer from what I expected, it was a shock, not a surprise, but a shock to me. So it was difficult to navigate in the first and second interview, but by the time I had reached the sixth interview, I had to like keep all of this aside. Otherwise, it would not give this type of a result. In the result that I presented would not give this type of a result for this research paper. Yeah.
Thank you so much. Very, very nice.
Thank you.
Thank you, Ms. Shivani. Before we move on, I would like if any of the presenters who have not sent it their PPT, please send it to the Gmail nsing@lq.amity.edu. Our next presenter is Joel Santosh and will present their qualitative study on changing religious perspectives of masculinity in the Indian context. Let's welcome them to the stage.
You might be shocked seeing that so many masculinity, but yes, let's move forward. Okay, I'm Joel Santosh, and I'm here to present more in-depth understanding of masculinity from religious perspective, and I'm under the guidance of Dr. Swati Pathak. And before starting even the research, one thing which I want to let you know that I'm a great advocate of the statement कि मर्द को दर्द नहीं होता. Okay, so the moment, the thought which you are having right now, which era he is from, or why is he having this orthodox or obsolete thought about this entire idea, is the idea what the paper is all about. That how we have changed, our thought has changed throughout history till now. Is what. So is there a change in the religious perspective from taking the religious lens and moving forward? So religious institution plays an important role in shaping our ideas, and especially the ideas related to masculinity and gender. And these teachings are always interpretation of the original text done by an authoritative person of the particular religion, like a priest or Maulvi or Guru. This research is done from that curiosity to understand the perspectival change happening in masculinity through religion. So while reading and going through the literature, there are a few things which came in front of me is how these early researchers were focused highly on showing this, that how religion plays an important role in reinforcing patriarchal structure. But later on, when we move forward, we can see a different understanding of how masculine understanding vary from the context they are from. So if they are from different castes or different social categories, you can see a different understanding of masculinity. And from that, the research gap have been understood. That is, there is a limited understanding of how Indian religious scholars themselves interpret masculinity. Why? Because as I said, that this understanding of masculinity in religion comes from the space of interpretation of religious scholars. Yeah. And the need to examine the evolution of masculinity interpretation with a specific religious tradition, potential of religious teaching to contribute the gender equality and remains unexplored. The research question, which I was focusing in this entire study was how Indian religious scholars interpret masculinity in original religious texts. What factors have influenced the change of religious perspective on masculinity, and how do contemporary Indian religious scholars negotiate between traditional and modern understanding? So the theoretical framework, as you have keep on hearing, is we have yeah, is Connell's theory of masculinity, Connell's and Messerschmitt's concept of masculinity. You have understood the hegemonic masculinity and everything, but especially focusing on understanding dominant masculinity and hegemonic masculinity, there is a difference. And what is hegemonic masculinity? It's a form of masculinity that legitimates and inequality between genders and having that discrimination and other things using the traits is what the hegemonic masculinity is all about. And this framework is used to understand the original scripture, understanding masculinity, and thus promotes the hegemonic masculinity. And methodology is again the qualitative research approach. I have interviewed 5 male religious scholar and 1 female religious scholar from Hindu, Islam, and Christianity, and scholars selected based on their expertise of their religion, professing their religion from minimum 10 years of experience from their particular religion, and interview based conducted on Zoom, which lasted somewhere in 50 to 70 minutes. An interview focus was more on interpretation of masculinity, religious texts, observed change, negotiation between traditional and modern views. And the data analysis was done using thematic analysis by Braun and Clark. So this is the theme and sub-theme which was understood from this entire process. And I want you to take a little focus and remember the arrow you can see over there, which has orange, red, and red mixed orange. So the first theme which came out from this entire process was the original religious conception of masculinity. The first theme talks about how original text focuses spiritual qualities over physical attributes. I'm not saying there's no physical attributes, but how it is focused more on spiritual qualities. And religious ideals like Prophet Muhammad or Jesus Christ or Hindu deities demonstrate moral character rather than dominance. And there was a very insightful point over there that how these teachings, original teachings, are presented, masculine virtues are not limited among genders. So there is a flow of understanding that this masculine trait in religion can also be in feminine person, or a feminine quality can also be in a masculine, a male person, was an insight which was understood. And the theme 2 is about the historical transformation of religious masculinity. So the original text has something. Then when we move forward, we can see how religious teachings were selectively interpreted to maintain a particular gender hierarchy. And scriptural interpretation were also influenced by external influences like colonialization or cultural change and things like that were also impacting the understanding of how religious scholars is showing interpreting the scripture, and religious legitimization of inequality through misinterpretation of the text. And theme 3 is focusing on contemporary negotiation of religious masculinity. So now the younger generation is questioning the traditional interpretation of religious text and the evolution of religious leadership and authoritative structures. Religious scholars actively working to recover the original scripture meaning. So let's talk about the arrow. So we all, as this study talks about how we have started from a one particular original text, understanding of the text, and how the text is understood. When it moved to the context of the people, the Sitzen of the people, there is a little twist where people started using a particular scripture. Women should not talk among the male is one of the scripture from Bible. The scriptures have been taken in understanding, misinterpreting the total thing over there. And later on, now when we see, we have moved from this orange to a orange mixed red, a darker shade of orange, but then we are not red anymore. We are not orange anymore. but then we have a mixture of traditionality, but also something coming out of something new coming out of which is revolutionized. And just like we can also see scholars engaging in restoring interpretation. Satam, that we are restoring the entire interpretation coming back. Religious texts offer both roots and gender hierarchy and tools to dismantle. And key components in the entire journey is interpretation. So implications are training religious leaders to incorporate the original inclusive text in the masculinity, creates a common ground across cross-faith dialogues about gender equality, and help religious men embrace inclusive identities while maintaining faith commitments. Limitations, as I have shared, the sample size was only 6 religious scholars, and it was also focused more on urban perspective. Why? Because the research while I was doing was done in English, and in Indian context, we also need Hindi to do. So because of time constraint, I had to do English. So there was a limitation like that. And also limited female representation. There was only one female scholar was interviewed, and primary representation of mainstream religious interpretation. Now, so future direction, one thing which I want to focus is including whatever we saw in limitation and coming up with something new is the future implication. Thank you so much. Open to questions and discussion. Yeah, it's a very good question. The same question which I had, that what if this result, which I'm seeing also an interpretation of today's context, something which we have to work on. And I guess the working should be more on understanding the in-text reading, that is exegesis of the passage. So exegesis of passage would take a very good amount of time, which in the shorter period of this research, I am not able to do. But what I have done in the entire research is I'm a theological background person, now moved to psychology. So I have done exegesis from throughout 5 years of my bachelor studies. So there is a interpretation or background understanding of what the scripture is saying is there. But then in this research, if you have asked me, that approach is very good. If I'm doing a very long study and taking time, going through each passages and interpreting in Sanskrit and interpreting in Hebrew, and things like that, that would work. And that will be doing in further if I will move forward with the research. Thank you.
Yes, you have quoted one thing, nature, that must could have been your time. I am not even in this, must could have been your time.
Absolutely, sir.
But our society or family raised a male person, such kind of people that it cannot express their emotions, their feelings in front of others. Okay. This is it. And you will get on a sixth sample. Do you think this is enough for a qualification?
No, not at all, sir. The thing was, you might have seen, so many masculinity papers are coming up. So it was a group research actually. And we had a lot of data on those time. But then now when it has become the individual paper, this is one limitation which we all are facing. And when we are moving forward with more, this paper, when I'm moving forward, I would be including more scholars in this spaces. That would be seen.
In fact, the qualitative research then us to do more sample size to for explanation of material, which is a pilot kind of study. And other thing is that if you want to study masculinity and femininity, yes, you have essentially shifted to theology to the psychology. There are theories that masculinity and femininity both are important for human being, what we report also. So that will also the help to interpret your results in the context of the future. Thank you.
Thank you, sir. So 2 points. Thank you so much for your input. I would be including that things in my upcoming research, and ending up with, I also don't believe mat ko dard nahi hota. It does pain. Thank you. My personal understanding, yes, ma'am. So I have focused more, even though I had to study many religious scripture, but I expertise in Bible. So Christianity is what I expertise, and there are so many scriptural which have taken. Like if I will take First Peter, there is an understanding of how women should be submissive under men, and there is in Acts of no. So in some other passages they talk about how women should be silent among men. So this understanding is there, but then usually how other scholars or previous scholars used to do was take that particular line and just interpret it however they feel and however they can submit, make the other gender submissive. But then now we can see a different flow and countercultural movement happening, where this entire idea is being questioned and bringing context into it, that in Greek context, how this makes sense and how it is different. So that is there. So you can see that change of countercultural over here.
You have not explored any other research apart from Bible.
No, I have explored. So the concept of Shiv Shakti, the understanding of Shiv Shakti is how male and feminine is one. So this understanding. No, that's what. No. So just to clarify that, the reason why I have stated that statement is to give everyone a thought that what my paper is about, how people are changing their thinking, that what I'm thinking is not that.
Literature and then you have interviewed these scholars. So why only one female scholar?
The reason was I was not able to get, so I did snowball sample size, but
one female was chosen by intention or it is just by chance?
No, not like that, ma'am. I was only able to get one in the limited time because I'm doing it in the college. I have to submit my paper. So in that limited time, whatever I got was, I was able to put. So the snowball method, as sir said, I was keep on asking people. And one ma'am has said that, yes, I'm ready to. And also the component of language, that Hindi was a big problem in this entire research, not because of the research, but then the problem was the interview process would have taken longer time. So I was able to get only very, selected amount of people for this research.
As you all the students have used the qualitative method and thematic analysis. So is there any other analysis that we can use under this qualitative term? Any other method that we can use?
I'm not sure if I'm stating this right, but we can also have a grounded theory, what I feel, because we have to go to the roots and understanding, because as I said, that interpretation plays an important role, and also narrative analysis also plays an important role. Understanding the experience of the people might also play a role.
One more question, please.
It's very interesting presentation and very interesting perspective that you put forward. So this is not a question, but rather something for the sake of discussion. So there was a lot of talk from the house about how instead of interpretation of the various individuals, people have gone for the scriptures themselves. So one thing I'd like to cite is that scriptures themselves over various periods of time, they have been a source of interpretation. So scriptures, whatever is written, they can either be taken at face value or it can be interpreted by different communities and different stratas of the society in different ways. That is why there is so much of subjectivity regarding religion, the same religion in different countries and among different stratas of people. Right. So one cannot actually take the scriptures in a very absolute sense. So of course, I do understand that why you have taken scholars, because somewhere scriptures are open to everybody's own interpretation and their own belief system, which can be reinforced or maybe changed by the scriptures themselves. So for this particular research, it's actually not possible to go for absolute scientific, facts for scriptures at least. So it was a very nice presentation. Congratulations. That's all I wanted to add.
Yeah, thank you so much. I would also add that whatever ma'am has said has make a lot of sense because everything depends on the context and the situation of the person. Thank you so much.
Thank you, Mr. Joel. Now up next, we have Atisha James, who will present a qualitative study on changing women's perspective on masculinity in India.
Good afternoon, everyone. Good afternoon to the esteemed panel and all the audience present. I promise this will be the last masculinity presentation. And so you all have heard about male perspectives, the perspectives of LGBTQ community, the religious perspectives on masculinity. Today, my topic is exploring the changing women's perspectives on masculinity in the Indian context. All right, so masculinity as defined already is an idea, sorry. Masculinity has traditionally been associated with a quality that believes that men should be dominant, have strength, and it associates with emotional restraint in India. But through researches, through a lot of literature reviews, it was found that various social, cultural, and media influences have changed these ideals and have brought a transformation, leading to a shift in how men express masculinity and how women perceive it. So, Banerjee, in his paper, argued that due to a lot of factors, ideas of masculinity have changed considerably from ancient times to now, the contemporary global influences. The study is grounded in Connell's theory of hegemonic masculinity, which says that masculinity is a hierarchy, and a masculine person, a man should embody qualities such as strength, aggression, and dominance in their life. And recent studies have explored on women's perspectives of masculinity, and the studies have suggested that women's conceptions of ideal masculinity have found that
Excuse me. We just come to the result analysis and the methodology.
All right, all right.
Already shared and discussed.
Can I start from here? So my research's aim was to understand how women perceive and interpret masculinity in contemporary India, to analyze the shift from traditional masculine ideals to how it is now perceived. And the objectives of my interview were examining the generational differences that women's expectations of masculinity, exploring the role of media and social norms in shaping these perspectives, understanding how women perceive masculinity in relationships, workplaces, and society. The method of my paper is a qualitative research was done and with semi-structured interviews. Participants were 7. They were all women aged 20 to 32 years from Delhi and Ghaziabad regions. Uh, the data analysis was done through Brown and Clark's thematic analysis, and participants were given informed consent and their identities were kept confidential. The results of my paper were I came down to 3 themes, overall themes, and the first was dynamic shifts in masculine identity. The sub-theme under it were redefining masculinity across generation. Now, women in the interviews noted that many men that in their lives itself, they have observed that older men tend to, adapt the hegemonic masculinity ideals, the qualities that were mentioned in the traditional notions. And while younger men are observed to be more open to emotional expression and shared responsibilities with women, embracing emotional expression and vulnerability. Traits like openness, emotional intelligence, and communication skills are increasingly valued in male partners nowadays in women. Navigating gender role flexibility. Women expect men to contribute more to their own tasks, to basic household tasks, basic living tasks, and breaking away from the traditional gender notions. And the concept of masculinity has become more fluid. I remember very distinctly one of the participants saying that masculinity is not just about men, it is a quality that can be seen, which shows that is a person being more strong and, strength is portrayed, somebody who's dominant. Yeah. The next theme is cultural and media forces shaping masculine identity. So basically, most of my interviews, the common theme was how social media has impacted the way women now masculinity is perceived. So societal norms and expectations of masculinity. Women observe that men face pressure to conform to expectations of protection, provision, and decision making as key masculine traits, often struggling with balancing modern ideals and traditional responsibilities because of how the society has uh, defined what masculinity is. The impact of media and social media. Social media allows for wider discussions on gender roles, making inclusive masculinity more socially acceptable. It portrays men as caring partners and involved fathers. So a lot of discussions that have arose out of social media have impacted the way people have perceived masculinity now. Protectiveness and security.
Tisha, can you tell us about the major, your understanding about the result?
Okay, so women's perspective mostly centers around how they have adopted a newer perspective of men being able to express themselves, being more emotionally vulnerable instead of just having that restraint, having to show up and be dominant and have a strength. And a lot of women believe now that men should have the avenue to express themselves, be vulnerable, and not just conform to the ideals, traditional notions of how masculinity should be. So women really believe that that would help men to, open up more. And
Okay. This understanding how it is different from your data collection analysis, your research analysis, and your observation. What is your actual observation? Is there any disparity between these two observations?
Research, the data collected, the themes suggested this result. And my observation is that uh, women do feel that there are mixed reviews. There are women who think that men should take up responsibility and should have a, a should follow the ideals in a moderate way, but not have to follow the strength and dominance and be very restricted to it. But also, women believe that men should really be able to have the space to open up, be emotionally vulnerable, and yeah, not have to suppress their emotions.
Thank you so much. Any other question from the audience? Thank you so much.
Thank you. Thank you. Next up, we have Astha Malik, who will be presenting on the relationship between perceived stress, coping strategies, and locus of control among young adults, with a focus on gender perspectives. Slide today.
Have you ever felt no matter how hard you try, stress keeps catching up with you? Now imagine how different people, men and women, deal with that stress. Do they handle that differently? Let's dive in further into this. Good evening, everyone. Good afternoon, everyone. I'm Asta, and my topic is relationship between perceived stress, coping strategies, and locus of control among young adults, a gender perspective. Starting with the introduction, perceived stress is the feeling or thought that an individual has about how much stress they are under at a given point of time. Coping strategies are the behavioral and the cognitive tactics that are used to manage crisis, conditions, and demands that are appraised as distressing. And locus of control refers to the degree to which an individual feels they have a sense of agency in regard to their life.
Sorry to interrupt you, sir. Can you directly come to the methodology section?
Sure. The objective again of my research was to explore the relationship between perceived stress, coping strategies, and locus of control among young adults with a special focus on gender perspective. Uh, so, for my research, 4 hypotheses were framed. The first one was that there will be a significant difference between males and females on perceived stress. Gender will affect significantly on coping strategies of young adults. Gender will affect significantly on locus of control of young adults. And there will be a significant relationship between perceived stress, coping strategies, and locus of control. For the sample, 100 students were there from which the data was collected, 50 males and 50 females from Amity University, Lucknow, age ranging from 18 to 25 years of age. The scales that were utilized were perceived stress scale, coping strategy scale, and Rotter's locus of control scale. The statistical analysis techniques that were utilized were t-test to assess the gender differences among the 3 variables, and Pearson correlation coefficient was used to examine the relationship between the 3 variables. Now, results. The result reveals that no significant gender differences were observed in perceived stress, coping strategies, and locus of control. The Pearson correlation coefficient that was utilized to assess the difference relationship between the three variables revealed that locus of control had a negative sorry, locus of control negatively correlated with cognitive behavioral coping strategies. That means those who have a higher, who had an external locus of control were less likely to use cognitive behavioral coping strategies, and perceived stress correlated with positively with behavioral and coping, cognitive coping strategies. Coming to the discussion part, this study challenges the idea that men and women experience stress and coping in fundamentally different ways. Unlike the previous studies that pointed clear gender differences in stress level, coping strategies, and locus of control, the findings here suggest that both genders handle stress in similar ways. This shift could be possibly due to the changing societal rules and the greater gender equality, making the challenges and coping mechanism of young adults more alike than previously assumed. While some studies have suggested that women tend to report higher stress level due to emotional sensitivity or societal pressures, this study indicates that the stressors affecting both genders today might be more similar than expected. Another key finding is that an individual's belief in their level of control over their life events, whether internal or external, doesn't have a strong impact on their stress levels. However, people who experience high stress tend to rely actively on active coping strategies. So we see that those who had an external locus of control were less likely to use cognitive behavioral coping strategies. And this suggests that while an individual's view of how they attribute their life events, that have an effect on how they respond to stress also. And these insights reinforce the complexity of stress and coping, and showing that the personal perceptions and responses vary widely. Coming to the implication. The practical implications could be utilized in mental health interventions, in education and workplace policies, and therapy and counseling. The limitations of my study were that the sample size was small, so we couldn't generalize the result to a larger population. And since self-report values were used, so it could lead to bias.
Also, you mentioned inclusion and exclusion criteria that what values we have considered. Age mentioned in the slide. What was the age?
18 to 25 years.
18 to 25. And
50 males and 50 females.
Have you explored the Indian researches on these variables?
Ma'am, there were not a lot of Indian researchers were done, especially in an academic setting. Ma'am, in academic settings that I was focusing on, there weren't much researchers. So that was my aim.
Thank you, Vasa. It's a kind request to all the other presenters to just keep it short and just do the presentation a bit early. Our next up is Swatantra Kumar with the topic Acceptance of Illness and Medication Adherence among Patients with Multi-Drug Resistant TB.
Good afternoon. My name is Swatantra. I'm a clinical psychology student. Today I'll be presenting my paper entitled Acceptance of Illness and Medication Adherence Among Patients with Multi-Drug Tuberculosis, a cross-sectional study. MDR-TB is a form of tuberculosis caused by mycobacterium, which is not only impact the physical health, but also the mental health of the people. My objective was to assess the illness acceptance and medication adherence among MDR-TB patients and to examine the relationship between illness acceptance and medication adherence. And my hypothesis was there is no significant relationship between illness acceptance and medication adherence among TB patients. Illness acceptance does not significantly predict the adherence. So my descriptive statics, Pearson correlation, and linear regressions were used. My basic key findings were moderate level of illness acceptance and medication adherence among the sample, and significant negative correlation between illness acceptance and medication adherence. Score among the higher illness acceptance was associated with the better adherence. Illness acceptance significantly predict better medication adherence. In discussion, the findings highlight the psychological impact of MDR-TB patients. Patients with higher illness acceptance appears to engage in better with treatment, and psychological barriers like stigma, financial constraint, and negatively affects adhering, requiring target intervention. Clinical implications, acceptance and commitment therapy and patient education program may improve illness acceptance and consequent adherence. Currently, I am conducting an intervention and study of efficacy of acceptance and commitment therapy on illness acceptance and medication adherence among MDR-TB patients. Thank you.
Thank you, Swatantra. Finally, we have Nikita, who will be presenting a systematic review on illness acceptance and perceived social support in the early and advanced stages of liver cirrhosis.
Good evening, everyone. My name is Nikita and I'm in clinical psychology trainee, second year. I will be presenting my paper on illness acceptance and perceived social support in early and advanced stages of liver cirrhosis. In this paper, we will be discussing how will as the disease progresses, as liver cirrhosis progresses, how illness acceptance and perceived social support varies among these stages. This is the introduction. I'll skip to the the study design. It's a systematic narrative review following the PRISMA guidelines. Search strategies use database from PubMed, ResearchGate, Journal of Hepatology. Keywords were illness acceptance, liver cirrhosis, perceived social support. Inclusion criteria, peer-reviewed research, English language, focus on illness acceptance and social support. Exclusion criteria, studies unrelated to psychosocial factors. Abstracts and case reports, single studies were excluded. This was the procedure of how the final papers were selected. Initially, 320 papers were identified, out of which 40 were excluded in screening. 200 were excluded because of wrong population, wrong study, irrelevant outcomes. Full text articles, out of which 63 were excluded because of no psychosocial focus, incomplete data, not in English, in different languages. At the end, total 17 studies were included in the systematic review, which out of which 6 were cross-sectional studies, 4 were longitudinal, 3 qualitative, 3 intervention-based, and 1 systematic review. The findings: illness acceptance in stage 1 liver cirrhosis is on low to moderate due to minimal symptoms leading to denial and delayed lifestyle changes. However, education, medical support, and early behavioral modification can improve acceptance and slow disease progression in advanced cirrhosis. Whereas symptoms like jaundice and astrocytes are evident, acceptance tends to increase, but it is often accompanied by emotional distress and fear of complications. Findings in respect to social support. In early stage cirrhosis, perceived social support often lower as mild symptoms lead to self-sufficiency and limited external help. Family and friends may underestimate the seriousness, reducing emotional or instrumental support. In advanced cirrhosis, support tends to increase due to greater dependence on caregiver for medical and daily needs. Last part discussion. Illness acceptance and perceived social support evolve in liver cirrhosis stages, shaping psychological adjustment. In early stage cirrhosis, low acceptance due to denial and minimal symptoms often lead to reduced social support as individuals feel self-sufficient and their condition is underestimated. In advanced cirrhosis, acceptance increase with worsening symptoms but may be accompanied by distress and fear. Social support also rise due to greater dependence, though some may experience feeling of burden or withdrawal. These are the references. Thank you.
Once again, thank you to all the presenters for sharing their invaluable research with us today. I would like to extend my heartfelt gratitude to our chairperson, Dr. Chaya Gupta ma'am, and co-chairperson, Dr. Madhu Pandey ma'am. And now I would like to call Dr. Rakesh Tripathi sir to felicitate Dr. Chaya Gupta ma'am and Madhu Pandey ma'am. It's a kind request for AIRS and IBA students to please wait so as to get your attendance marked. As you leave, please get your attendance marked. All the registered participants can move for the lunch.
Yes. Okay, sir. I request everybody to please settle down. So we will start in 5 minutes. Those who are seated at the back, kindly join us in the further seats, in front seats. Ladies and gentlemen, welcome back after what I hope was a refreshing lunch break. I am Kriti Sharma from Clinical Psychology Department. Have the proud privilege to be your host for this event. As we reconvene for the second half of today's proceedings, we continue our exploration of critical issues in community health, mental well being, and neuroscience. This session promises to be insightful with distinguished experts sharing their knowledge and research findings on some of the most pressing topics in mental health today. Without a further ado, we now move to our next lecture, and I would like to call upon stage Professor S.Z. Zaidi sir and Dr. Anil Kumar Tiwari sir.
Sir, I am Zafar Zaidi. And good morning as per UK time and good afternoon as per Indian Standard Time. Friends, my dear colleagues sitting over here, our interaction with Professor Afzal Javed goes back to when we met in PGI Diamond Jubilee celebrations, where sir was invited as a chief guest and I was one of the participants. His deliberation, his understanding of the subject, his interaction with the people around there was so impressive, so grassroots level. He was talking about everything which is required. So I immediately requested him to join us in one of such academic interaction. And he immediately agreed. And from there, I was searching an occasion to invite him. And on my first request, he immediately agreed to that yes, I will join I remember you, I'll join your program. And from there out, it was, I think, perhaps July, August, before I was planning to this, I have taken his consent, sir. And you immediately replied, very encouraging reply that, yes, I will join you, go ahead with that. And now the right time has come. When sir is here, online, of course, and our audience is there. Sir, I, on behalf of MIT University, MIT Universe, having 16 campuses, different parts of India and many abroad, including London, welcome you and our Deputy Pro Vice Chancellor, Wing Commander Anil Tiwari is also here and he is in the chair. And I would be requesting Wing Commander, sir, to have few words with Professor Afzal Javed. He is an immediate past president of World Psychiatric Association, the highest position which you can think of it in any professional body. So once again, over to sir. Can you have few words with him?
Good morning, Professor Javed. Good morning, ladies and gentlemen. It's indeed an honor for Amity University, Lucknow campus to host such an eminent psychologist, consultant psychiatrist. I stand corrected. As a layman, these nuances one would need to pick up. A very warm welcome to you, sir. And this welcome is not on just behalf of the Amity University Lucknow campus, but on behalf of our founder president, Dr. Ashok K. Chauhan, under whose visionary leadership we are able to organize these international events. The warm welcome is also on behalf of our chairman and chancellor, Amity University, Dr. Aseem Chauhan ji, whose vision to take education to the next level, a great thought leader, knows no bound. I'm indeed honored to host you for this session, sir, for the topic, mental health challenges of the cyber world. A very, very apt topic. Ladies and gentlemen, Dr. Afzal Javed is a renowned consultant psychiatrist and professor at Institute of Applied Health and Research, University of Birmingham. An eminent scholar, Dr. Javed specializes in social and psychosocial rehabilitation. Dr. Javed has published around 8 books, 150 scientific papers, and monographs. Dr. Javed is a member of several national and international associations and recipient of various national awards. Indeed, it's an honor to have you here, sir, to deliver this so apt lecture on the most relevant topic on mental health challenges of the cyber world. Over to you, sir.
Good afternoon, Dr. Tiwari, Professor Zaidi, and Honorable and respectable faculty members of MT University, and dear participants and attendees. I'm grateful to Professor Zedi and the organizing committee for inviting me to this very prestigious conference. I wish I could have been there in person to experience the great hospitality of Lucknow, but internet and online conversations have almost become a norm in our life. The topic which has been given to me is of a lot of interest and gaining importance in our day-to-day life. What I will try to cover about some of the issues relating to cybersecurity, online use, and the implications specifically for mental health. I do not have any conflict of interest for this presentation. As we know, 21st century is the century of IT and AI. And we are depending heavily on technology for internet and communicating with each other via online. As the use of internet is increasing, we are also witnessing a number of concerns, a number of issues. As the time is limited, I have just mentioned these three major areas: internet addiction, post-COVID use of internet. But for this presentation, I will be concentrating on cybersecurity, cyber attacks, and its implications for mental health. As you know, the post-COVID, the time spent online has increased, and at the same time, the cybercrime has also grown dramatically. Similarly, the current literature emphasizes a lot on internet addiction, although the major classifications in psychiatry have not included internet addiction as a disorder, but there has been a lot of concerns about issues related to the use of internet in this way. So as I said that, I will concentrate on the third aspect of internet current usage, and that is cybersecurity. What are the harms associated with cyber attacks? And in particular, what are the implications for mental health? As I said, this is the century of IT and AI. And we are using this technology in a big way. While we are having this technology used for our daily social, scientific purposes, we are also experiencing several risks from the use of digital internet. And these harms or dependence in another way has seen a profound change with our increased usage of internet at home, at work, at school, shopping, entertainment visits, or even with the health professionals. And with the passage of time, the seen about cybercrime is also changing. And it ranges from financial crime to our social life, fabrics of the society, and resulting in long-lasting effects. Similarly, mental health is also witnessing an increased problem, not only for the professionals, but also for the users of health and in particular mental health services. What are the cyber attacks? Usually, the literature emphasizes on these three types of attacks: disabling of the computers, stealing data, and compromising systems to launch further attacks. So if we look at these types of attacks, these are implicated with a wide range of impacts on our personal, social, and work life. And society is depending heavily on technology for our interactions, commerce, and businesses. And cyber harm is defined as the damage that arises as a direct result of an attack conducted wholly or partially via digital infrastructure. And to understand the nature of such attacks, it is critical that we know and we keep an eye on the effects that we are witnessing, along with some good results and good use. As I said, that with the increased use of internet and cyber technology, the cyber attacks have also grown increasingly in a very sophisticated way. And cyber attacks are more than just data breaches. These can have deep psychological scars affecting victims' mental health, and it is very crucial that we need to acknowledge and understand the harmful effects with the view to find out how can we really control this. And since COVID-19, the increased dependency on internet use is making us more vulnerable. And while we are enjoying the good effects, we are also paying the price in terms of the cyber attacks. Generally, these are 5 types of risks: physical or digital harm, economic harm, social and societal harm, reputational harm, and psychological harm. As these cyber harms result from cyber attacks, so these 5 types of harms can take different forms, different formats, and different impacts. Physical or digital harm describe a physical or digital effect, negative effect. Economic harm that could result into financial and economic consequences because of the attack. Psychological harm, which I will go into details in a minute. And of course, the attack also result into the reputational harm and social and societal harm. So coming to the main topic, psychological harm. What is psychological harm within the perspectives of cyber crimes? So this is the harm which focuses on individuals and their mental well-being and psyche. Cybersecurity fears and their mental health effects lead to anxieties, worries, distress, and keeping and making people vulnerable. It is a big risk, and while victims are feeling anxious, worried, and in distress, they also often feel angry, isolated, embarrassed, and betrayed. And the breach also damage the trust between users and the providers. Specifically, when it comes to involving personal health data, especially sensitive mental health data, that could lead further damaging consequences and make people more worried about the impacts of these cyber attacks. And as you know, the personal data is very dear and very personal to the people. And if this breach occurs, it leads to the vulnerable people in particular more vulnerable for not coping with the situation. And personal data, including the health data, is now one of the most valuable forms of data. And cybersecurity breaches in the healthcare sector continues to grow. And that can have further impacts on the mental health. So what are the implications? Researchers have shown that under normal circumstances, a person would be able to detect a potential social engineering attack around 70% of the time. But when somebody becomes stressed, fatigued, or depressed due to the linkage with the internet or with the cyber media, then they become more likely to be victims of these kinds of attacks. And similarly, if people are stressed, they forget about the security linked to the internet, and they do not bother about checking about the origin of some of the data, emails, or messages. And obviously, that may lead to fraudulent messages and the consequences. It's a pity that despite its big impact, cybersecurity is not looked as it should be. For example, in a recent report issued by World Economic Forum, while they were talking about the toolkits for digital mental health, the word cybersecurity is mentioned only once. So this means that while we are talking about implications of cyber attacks, this is not being given a priority that it needs to have in terms of our understanding, our policy making, and our practical work related to this one. So going a bit more specific, what are the impacts of cyber attacks? No health without mental health. We have been listening to this slogan for years. mental health is obviously important to us. But what happens? That most of us, even including the professionals, we only consider mental health linked to the mental illness. And we forget that there is a component in between the health and the illness, and that is the well-being. So good mental health is not only absence of mental illness, but also about how do we feel and how do we interact. So just looking at this, when it comes to any fears, attacks, or any threats, it is common to develop some mental symptoms, but not necessarily everyone will suffer with the illnesses. But one thing is sure, that the mental well-being of most of the individuals who are prone to these vulnerabilities get affected. So it is imperative to bring issues and efforts about the consequences of mental health problems, and similarly looking at the mental health support systems while we are using the cyber technology in a big way. And we also need to make sure that the attitudes and the availability of the support in this particular aspect is equally important as important the technology itself. There is no doubt that the attention is being given to the impacts of these attacks, not only from technological aspects, but also from psychological aspects. But we have not been able to achieve a lot despite its growing nature and growing extent. So how can cyber breach harm victims? It can harm in multiple ways. It could potentially trigger anxiety. It could potentially trigger suspiciousness, depression, and even feeling of worthlessness. You just imagine that you have done a lot of work and your data is breached. How would you feel in terms of the coping with that? And then, if these cyber crimes involve the attacks on interpersonal issues, disclosures, personal health data, or even naming the people in terms of the therapy sessions, what could be the impact? And of course, if we see the fraudulent nature of many of these attacks that result in financial harm, that of course is directly or indirectly linked to fraud, identity theft, and financial hardship. And it is not only the person who is vulnerable or who is at the receiving end. The impact can also to the closed society or circle of the victims as a result of this data breach. And in the West, and I'm sure that India as a country is technically as sound as the West, the issues, specifically the breach of personal data, is being taken very seriously. So some of the symptoms that can emerge may not necessarily lead to actual mental health disorders, but certainly makes people vulnerable for their well-being. For example, victims of computer misuse report psychological harm such as anger, isolation, embarrassment. The victims of identify theft after a data breach may become even violated, betrayed, angry, and powerless. And this could, in many cases, lead to the stages of grief, guilt, and feeling shame. Children in particular are at a heightened exploitation risk. And we have seen in the media, many professionals are seeing this in their day-to-day practice, that unfortunately, the exploitation and the data breach can actually lead to a number of illegal hacking activities, performing illegal online financial transactions, or even some sexual explicit contentions. So mental health impacts can be summarized that cyber crimes like hack attacks can lead to severe emotional distress, not just financial issues. And there may be a number of psychological presentations, symptoms, and feelings that could directly or indirectly affect the well-being. And similarly, many cybercrime victims feel powerless because many times we are unable to overcome or stop these illegal activities. And this cycle of issues with mental well-being obviously lead to number of symptoms and issues that could again affect well-being and confidence at the work. So in conclusion, the cyber attack landscape is looking at some of the damaging effects. While the use of cyber technology is on increase, it has become almost a part and parcel of our life. And this threat to this cyber landscape is certainly making us feel concerned. And we do know that with the advancement in the technology, there are increasingly sophisticated tools and attack methods. And networks that encourage and enable the distribution of cyber profits, financial issues, greater availability of skills, external factors, all these contribute to have some damaging effect on this cyber landscape. Just to give you the extent of the problem, the government of UK Home Office and the Department of Science, Innovations and Technology released their official statistics after a cybersecurity breaches survey last year. And it is worth noting that it is not rare. It still remains as a common threat. And looking at the extent, almost half of the businesses and about 1/3 of the charities, they experience some form of security breach. And it is not only targeting the major businesses, even the small businesses and the medium businesses are also paying the price. And some of the common types of breach are spams, impersonating organizations, malicious software programs, and as we see that while we are having an advanced technology for our cyber use, the methods of cyber attacks are also getting more and more sophisticated. So while we have to use the cyber technology, the threats of cyber attacks will always be there. And cyber criminals continue to look for new and innovative ways to infiltrate organizations. So now this is really a need of the time that we not only work on the extent of the problem, we not only discuss the impacts of the cyber attacks, we should also try to look at different types of harms that could include physical, digital, economic, psychological, reputational, and social and societal harms. We have to be mindful that this issue is increasing as our use is increasing. So it could be that at the moment we can only think of these 5 harms. The future will add few more. But one thing with all harms will stay as important and very significant, and that is the psychological harm. So we have to really keep this in mind, that interventions, support systems, and more importantly, understanding the consequences need to be not only publicized, but also people needs more awareness. So what are the future directions? Of course, we need not to be pessimistic. Let's hope for the best. And I personally feel that while technological advancements are taking place at each department, whether this is education, business, industry, while investments in IT are resulting in profit and prosperity, we have to keep how can we combat the threats of cyber attacks, particularly in terms of their mental health impacts. I'm not saying that mental health impacts are the only impacts or consequences. There are many other consequences which may be even of greater intensity. But as I mentioned earlier, that one has to be of stable and in a well-being position to carry on different aspects of our day-to-day activity. So we need future work to look at different types of cyber harms, but more importantly, how can we prevent these harms and how can we introduce this particular topic in the curriculum of our studies. While the courses, the programs are set about creating awareness about cyber technology, I think we need to emphasize equally on identifying and finding the support system for cyber crimes. So technology certainly is providing powerful tools, but we have to ensure that these tools are used appropriately. And support for cyber threat researches and encouraging studies for evaluation and outcome become even more important for mental health professionals, for academic departments of mental health, psychology, psychiatry, or sociology. And we would consider including cybersecurity and digital mental health training in the curriculums, especially for our professionals who are dealing with the mental well-being of the society. And we have to also create some awareness about international base and navigate a growing number of complex systems for regulations and for their standards. So just to finish, the future directions not only ask for assessing the current and the future at risks, but also improving the security of systems. And more importantly, managing disruptions in the mental health and for implementing victim support services, which are going to be an important part and parcel of our future directions. Sir, I'm really grateful to the university and to the organizers for giving me a chance to share my views. Unfortunately, I have not been able to cover many of the aspects related to it, but because of the time, I thought that I should be a bit more precise and focused in terms of this particular topic. Thank you very much.
Thank you, Professor Dr. Afzal Javed, sir, for your enlightening and thought-provoking lecture. Your insights into the mental health implication of cyber world have provided us with a deeper understanding of the challenges and responsibilities in this digital era. I now request our esteemed chairman, Wing Commander Dr. Anil Tiwari, sir, to share his valuable insight on this session.
At the outset, thank you very much, Professor Javed, for such an elaborate and lucid coverage of the entire topic. You being the epitome of knowledge in this area, it would be really stretching myself if I add on to what you have said, but I would just encapsulate the wisdom that you have put it in words. Professor spoke about cybersecurity and its impact on mental health. He talked about three aspects: internet addiction, post-COVID cybercrimes, cybersecurity harms associated with cyber attack. He explained in detail the third aspect, and he said, with increase in the online time, cybersecurity has become paramount. Indeed, that's been so. Post-COVID, we have seen the majority of the businesses have shifted online, and hence our vulnerability, not only financial vulnerability, but also our mental well-being has become a challenge under the cyber attacks. He spoke about cyber security, its breach results in financial and social impact, and how cyber attacks bring in different stress levels, data concealing, and other aspects. He spoke about cyber harm and methods of its mitigation and growing attacks and impact, especially on the mental health. He then elaborated on 5 different types of risk: physical, economical, psychological, reputation, and social. So very well covered. Cybersecurity implication for mental health were very well elucidated upon by him. He covered impact for cybersecurity, and then in last, he spoke at length about future directions for prevention. Thank you very much for such an elaborate coverage of the topic, sir. I think it's very, very apt because in a growing economy like India, which has aspirations to become 5 trillion economy and beyond and become a Viksit Bharat, there is no option but to turn towards a greater aspect of IT. And as we move on the IT, the world scenario in respect of psychological impact becomes very, very critical. The recent most advances in which brain-computer interface devices have increased in number. A large number of you must have heard of devices called Neuralink, in which now it's possible to place a device inside the brain for helping patients. Now imagine such a scenario. I'm talking about the future when you have a very effective brain-computer interface. That's the kind of a future we are talking about. And that is where Professor Javed's guidelines become very, very relevant. Why I mentioned this thing was, indeed, we have some of the brightest mind over here, and the Professor Javed's lecture would fuel a lot of interest in interdisciplinary subject. I'm indeed delighted and fortunate to be part of this discussion, being an engineer and my hands-on cybersecurity and online aspects. I indeed feel blessed to be part of this discussion. Thank you once again, Professor Javed, for such a nice coverage on the subject.
Thank you, sir. Now I would like to request Professor S.Z. Zedi, sir, to share his thoughts on this session.
After such a brilliant summing up and of the highly scholastic and practical presentation by Professor Afzal Javed, I have only 2 or 3 points for my practicing and young psychologist, that such cases you are going to have in number. It's increasing, as sir has very rightly said. Sir has used 2 very important words. That is psychological scar. That even after, if you meet with any accident, even after opening up your bandage and wound is healed up and all this thing, scar is left out. And many a time patient would keep on hiding that scar with worries and stress and with a lot of all words which you can say self-image and this and that. You are going to have such cases of cyber security, cyber crimes victim. The second is that it is harm because of the reputation is at stake. If somebody who has been all through extremely good, and one fine morning he gets a phone call or a letter from a bogus police office that you have been trapped in human trafficking or any recording the pornography and all these things, the first thing he would be worried about that whether my wife, my children are not aware of it. He would not realize immediately whether it is right or wrong. He would immediately start thinking that what about my reputation? How I will prove it? And the worry and the anxiety and the depression, all symptomatology which Professor Javed has very rightly, aptly has mentioned, would make him disturbed, upset for years together. So you have to take care of it. You have to develop the strategies of handling this thing through your counseling, through your support services, and you have to reassure that it is short-term, self-limiting scar, it would be removed. So with this, once again, I really thank you very much, Professor Javed, from bottom of my heart and on my official capacity, that you, in spite of your very busy schedule, you honored my request. And now I'm realizing that my visit of Chandigarh was very, very useful, very fruitful. And sir, I will request you to share few of your experiences in Punjabi, which we had in the Delhi last visit, which you shared there in Chandigarh, and we were laughing like anything.
Well, sir, you are speaking from जिसको हम कहते हैं कि उर्दू के गढ़ से आ रहे हैं. हमने तो उर्दू आप लोगों से सीखी है, तो पंजाबी तो ठीक है, पंजाबी अपनी जगह के ऊपर, लेकिन हमें फख्र है कि जब हम लखनवी अंदाज में उर्दू समझते हैं और सुनते हैं, शायरी देखते हैं, तो आपकी बड़ी मेहरबानी है. आपकी तो ये तो एक जबरदस्त काम आपने किया है. बहुत बहुत शुक्रिया सर आपका.
Thank you very much, sir. Thank you.
Thank you, esteemed speakers, for your valuable insights and reflections on this session. Your perspective has further enriched our understanding of the evolving landscape of mental health in digital age. I would now like to request Professor S.Z.H. Zedi sir to present a token of appreciation to our esteemed chairperson as a gesture of gratitude for his invaluable time and expertise.
Sir, see our limitation and the things that you are the main speaker, and we are not in a position to right now hand over this memento and certificate, but I'm sure that we'll be approaching you very short, definitely with the certificate. I will try to send our memento through courier.
Thank you very much, sir. Thank you very much. Your words are more than momentum for me.
Thank you very much, sir.
Thank you.
In an era where digital technology has been an integral part of our daily lives, the mental health implication of the cyber world cannot be overlooked. As we navigate the challenges of digital connectivity, it is imperative to develop strategies that safeguard mental well-being, promote responsible technology use, and foster a balanced approach to digital engagement. Having explored the impact of digital world on mental health, we now shift our focus to a topic that delves into the neuroscientific basis of sensory processing issue. As we continue, I am pleased to introduce our next distinguished speaker, Dr. Sanjay Kumar. Dr. Sanjay Kumar, an esteemed expert in cognitive and clinical neuroscience. He is the Assistant Director and Group Leader of the Cognition and Cognitive Neuroscience Research Group at Oxford Brookes University, UK, where he specializes in EEG, ERP, and TMS investigations and neuropsychological assessments. A chartered member of the British Psychological Society and senior fellow of advanced higher education, he is also a registered practitioner psychologist with the Health and Care Profession Council, United Kingdom. Underscoring his commitment to both academic excellence and clinical practice, we are privileged to have him with us today. Please welcome Dr. Sanjay Kumar. Chairing this session is a highly esteemed expert in neuropsychiatry, Dr. Haq Nizami. With over 3 decades of distinguished service, he has been a key figure in psychiatric education, research, and clinical practice. He has served as professor and director at the Central Institute of Psychiatry, Ranchi, where he has mentored numerous MD psychiatry and PhD clinical psychology candidates. An author of over 150 research papers and textbooks, His expertise is globally recognized, having served as a member of the WHO expert panel and the UPSC selection board. We are honored to have him chair this session. Please welcome Dr. Haq Nizami.
Hello. Hello.
We can hear you. We are able to hear you.
Yes, Dr. Sanjay Kumar.
Yes, sir. Yeah, we can hear you.
Yes, without any delay, already we are a little late. I would request you to please give your talk. Thank you.
Thank you. Okay, let me share my slides. Yeah, just confirming if you can see my slides.
Yes, sir, we can see the slides.
Okay, thank you. No, thank you so much for this wonderful opportunity. And I had a relatively long association with MIT University with Professor Jadi and his colleagues. I had visited last time when I was in India to the institute, and it was really wonderful to see the fantastic work that is going on. And this is another extension of those fantastic work that is going at the MIT campus in Lucknow. It's a challenge now after having heard from Professor Javed the wider landscape of cybersecurity issues and mental health problem. I will try to delve into a very specific area, and hopefully this would be a useful way to understand the research process, because that's what we had talked about last time when we visited the campus. So here I'm going to talk about a particular issue in ME or CFS condition. Those who are not very familiar with ME CFS, it is considered a neurological condition, although it is also very enigmatic. Causes and etiologies are unclear. It affects multiple systems of the body. Prevalence, looking based on the confirmed cases, is around 0.75 to 1%, that kind of range, but it can be much higher. But the idea about ME/CFS that has manifolded after the long COVID symptoms that emerged from the pandemic. And many of those long COVID cases, they are being, they manifest as the ME and CFS symptoms. The primary feature here would be the extreme fatigue, and that for the diagnostic purpose that may last more than 6 months. Symptoms, those fatigue particularly, it will worsen with physical or mental activity. And generally, they don't fully improve or recover with rest. So these are the distinguishing features in ME/CFS. Along with that, what we call as extreme exhaustion after physical or mental exercises, there would be problems in memory or thinking, typically is considered as brain fog. Dizziness that worsens with moving from lying down or sitting to a standing position, muscle or joint pain, unrefreshed sleep, and particularly the research that I'm going to focus on is around with this particular condition. They also become very sensitive to light or sound or smells of food or medicine. So even normal light for them will seem quite intense, or even general conversation may seem quite noisy to them. From the cognitive domain, because that's my area of research had been so far, and the cognitive problems, they are the mandatory criteria for ME and CFS, if you look at the Canadian consensus guidelines, where the main problem would be in attention, brain fog, as we talked about, where problem would be in working memory and concentration, and impairment in information processing. If we look at meta-analytic studies, there are a few which particularly reports on impairment in visual, spatial, and memory and reading speed. So what it seems that the rate of information processing or the speed of looking at the information, that might be a central feature of these processes. What they have, particularly looking at the cognitive mechanisms, they seem not to support the idea that there is executive function deficit. So these kind of responses or cognitive responses that can be also investigated at the brain level. And if you look at the functional brain activities, so there has been report of increased activity in bilateral parietal areas, cingulate cortex, and decreased activity in the prefrontal region. So multiple brain areas, there seems to be involved. Further on, if you look at the functional connectivity between different parts of the brain, particularly during the resting stage, there is a decreased functional connectivity during the resting stage, but there is increased functional connectivity during any challenging task. So that suggests that the brain is operating or the dysfunction we might be able to see with more challenging tasks in this particular condition. Then coming back to the central question, why shall we investigating sensory problem at all? There are reports that the sensory problems are very common in ME/CFS patients. Hypervigilance and sympathetic activities has been reported. As I was talking earlier, that many of those patients, they will report high sensitivity to light or noise, or even if you look at another chronic condition of MS, multiple sclerosis. So even compared with those conditions, this sensitivity seems to be much higher in this patient. So that suggests that the chronicity of the condition is not the causal factor for increased sensitivity in this patient group. If we further look at some report has suggested that those increased sensitivities seems to be particularly associated with increased number of symptoms. So, and therefore, it becomes important if we want to address the disability caused by those symptoms, then we shall also try to address the hypersensitivity issues. And it is not so unique a problem in only in ME and CFS that there would be hypersensitivity associated with symptoms presentation. If I can recall correctly, I think even Professor Nizami, they had shown sensitivity-related issue in schizophrenia patients and how they correlate with symptoms manifestations. So what do we know about so far the mechanisms behind this sensory processing problem? My first take is that we don't know much. It has been hardly investigated directly. Whatever there were little effort, they did not find much evidence for sensory processing problem from a neurological perspective. Again, further evidence did not suggest any particular issue with the sensory system process. There are some report, particularly in EEG ERP, a component is called P3 component, which happens at around 300 milliseconds after the stimulus onset. So in sensory processing term, it is a late processing. And so what we see here, that these changes may occur at the late information processing stage in the brain. However, there are some indirect evidence of sensory system involvements in MECFS. There are some study, fMRI study, which has looked into abnormal activity in the sensory cortices, but they were not task dependent to sensory process that might be associated with other cognitive tasks, but they also found effect of activity changes in the sensory cortices. In similar way, there was an fMRI study which looked into that there was a reduced responsiveness of the auditory cortices, and that was during the fatigue-inducing period. So again, there are no direct evidence, but we see that the sensory system is involved in this particular condition. Again, there was an increased visual cortex activation in mental imagery task. Again, mental imagery task is a cognitive task, not directly looking into the sensory processing. But what we observe here, that the visual cortex, which is associated with visual processing, that is abnormally active in this group. Some other work has also shown involvement of the parietal cortices, which is an area of multisensory integration, or the cingulate cortex, which is associated with filtering of information. So there are some indirect evidence. So I suppose, therefore, it is worth investigating sensory processing system directly. We talked about that those individuals, they get overwhelmed with sensory stimuli, which affects their personal, social, and professional lives. And these can lead to mental and physical fatigue. If we understand the sensory system, we know that these are fast systems and they are hierarchically organized systems. If you take an example of auditory information processing, that will ascend through a series of brain regions before it reaches the primary sensory cortex or the auditory cortex. It doesn't stop there. From there, it will move to, will be projected to secondary sensory cortices, which will then be projected to multisensory area of the prefrontal cortex. So you can see that there is a hierarchical organization, and it's a complex organization. When the sensory information reaches to the prefrontal cortex, which acts as a supervisory system, which can feed back its control system to the sensory cortex, and these feedback projections, that will change the nature of how the sensory information is being processed. So here, if you think of two different mechanisms are operating, one is the ascending pathway or a feed-forward pathway from very basic sensory system to the sensory cortex and going to the prefrontal cortex. And the prefrontal cortex, then it's sending back a control mechanism to the sensory information area. So it's an interconnected process and very fascinating processes that can occur. What we also call that as a bottom-up or early sensory processing, or the top-down based modulation, which is much more under the executive control mechanisms. Okay. So what the questions we can ask are based on how we know that how sensory systems work. The questions can have four possibilities. That there is a problem in an early sensory processing system, or the problem could be in a later top-down dependent system. The third possibility could be the problem is in both bottom and top-down systems. And the fourth possibility could be that there is no problem at all in sensory processing system, where the problem might be arising from some other system about which we don't have any idea, or at least through these mechanisms, we may not be able to answer that process. So I have kept my ideas open at this stage. I'm not expecting anything, and based on the findings, I will be able to suggest what the mechanisms I think might be supporting or not supporting these possibilities. How do we address these kind of challenges? I use EEG, and EEG, particularly because of its excellent temporal resolution, every millisecond kind of activity we can investigate. We understand that this sensory processing, they are fast processes. We need to go for that kind of time resolution to understand the process. I used two specific paradigms using pure auditory tone. So you can say that this is, or the findings might be applicable to the auditory system. So those two processes, paradigms that I have used, one is called the P50 suppression, where if you present one auditory stimulus and the second auditory stimulus in quick succession, your brain responses to the second stimulus will be reduced because the brain has adapted with the first stimulation. And that is taken as a ratio of a second stimulus by the first stimulus. Then the second paradigm I have used is called the oddball paradigm, where, again, using these auditory stimuli, if you present two different category of stimuli, one, let's say, high-pitched stimulus, and other low-pitched stimulus, and high-pitched stimulus can only occur very infrequently, let's say 20% of the time. And then you see the brain responses. And these kind of paradigm, they have been very effective in eliciting a P300 kind of component. Okay. One interpretation, there are several interpretations of P3 component, but within this context, what I am investigating, it can also reflect a mismatch between the context and the sensory input that we are receiving, or the brain is receiving. So here I'm going to present three lines of evidence, one based on the questionnaires. And in questionnaires, okay, so on the sample that we had 31 diagnosed patients and 31 control, which were matched for age and sex and ethnicity. As you would imagine that there would be higher level of psychological problems in these patients. So they had higher anxiety, higher depression, And because this is a disabling condition, there was a high rate of unemployment. So it is not a surprising finding. On the questionnaire, sensory profile questionnaire, what you see here, that on several of those indices in different category of sensory processing, these patients, ME/CFS patients, which are in blue, they have increased problem on those specific categories. So they report low registration, they report higher on low registration. I will explain what the low registration may mean. But if we look at in all these conditions, they are significantly different than the control group. So they have the reverse trend. Here you see that they are low on the sensation seeking, that they don't like to have sensory stimulation. And here you see that they are high on sensation avoidance. Okay, so let's try to understand what the low registration may indicate. So low registration indicate that there is some difficulty in reacting very weak stimulus. Okay, so those stimuli which are low in intensity, they will be missed. So these individuals generally will require a stronger stimulation. And you can imagine if they require a stronger stimulation, that is further going to complicate their sensory processing. Then we looked at that they had increased sensitivity, which indicates that they are quick response to those weak and low salience stimuli. They have an increased awareness of the details of the environment. So whatever smaller details that we can ignore otherwise, they are not able to ignore those smaller details. So if we look at all this, it indicates that it's a passive response pattern, that what we should have been able to ignore, that filtering mechanism, they are not able to ignore that. And overall, we can conceptualize that this seems to be much more erratic pattern of behavior. So sometimes you are trying to avoid something, sometimes you are trying to respond quickly. And again, whilst responding, you try to miss out the details as well. So it seems much more an erratic pattern of behavior. And if you try to think of erratic pattern of behavior, we can try to link that with the top-down mechanism where there is less control on sensory processing. Higher score on sensation avoidance, that is clear why they would like to avoid having exposure to sensory stimuli. They are, again, lower on sensation seeking. They are trying to avoid exposure to sensory stimuli. So, and in those avoidances that they do not find these sensory experiences really pleasurable. Then directly looking at those neurocognitive mechanisms, the second line of evidence. So we looked at P50 suppression. So the activity that we are looking at should occur around 50 milliseconds after the stimulus presentation. So as we talked earlier, the sensory processing is a very fast-paced, hierarchically organized. So we are looking at activity around 50 milliseconds around this time point over here. And there we do not see any difference between the control group and the patient group. Both of the group, they had similar kind of response pattern to second stimulus. So in a way, it indicates that the early sensory processing pathway seem to be working fine. However, when we look at much later in the time window, around 350 millisecond in this case, that's where we start seeing, based on the oddball task, that those individuals have a reduced amplitude for this sensory processing. So here at around 350 millisecond, which is much more later in the time processing course, that's where we start seeing that something is different in these individuals. Then we looked into some neuropsychological tests. So that this would be a third line of evidence and what we can find from the neuropsychological tests. We used motor screening task, which is related to attention and psychomotor speed, very basic processes. We did not find any difference between the group. We used rapid visual information processing, which was associated with sustained attention. Again, no difference between the group. However, we see the on the stop signal task, which is a response inhibition task, they show those changes. So they have a slower stop reaction time. They also have differences on a short-term working memory task or working. So they had slower reaction time. So based on these kind of pattern, which those basic attention-based mechanism versus here, which are much more executive function-based mechanisms, we do not see the processes differences at the basic mechanism, but we see the processes much more driven by the top-down mechanisms. So can we conclude based on these findings? So on the questionnaire based, again, we saw erratic patterns, which indicates a problem in cognitive control. We see reduced P3 amplitude, again, which indicates a top-down mediating a process is not working optimally. And those symptoms, they did correlate with the P3 amplitude. So overall, what I am proposing that there is a failure in the top-down mediated cognitive control systems, which are associated with those sensory problems in ME and CFS patients. And for this, I have provided those 3 lines of evidence looking very systematically what the problems had been and where they did not have any problem to. So these were the collaborators on the project, and indeed, I'm thankful for the ME Research UK to fund this project. And with this, I will end my talk. Thank you so much for listening.
Thank you, Dr. Kumar sir, for your in-depth and insightful presentation. Your expertise in cognitive neuroscience and sensory processing has provided us with valuable perspectives on the mechanism underlying chronic fatigue syndrome. I now request our esteemed chairperson, Dr. Haq Nizami, to share his thoughts on this session.
At the outset, let me say that this has been a very interesting talk. And in a brief, while it has been done in such an definitive way, covering very intricate, complex areas of work. At the outset, the very topic that we have taken, chronic fatigue syndrome, the manifestation is common, so common that epidemiologically, you may find in the population around 25%, but when you are going to diagnose it, not even 1%. and variety of other conditions do have this kind of presentation, that becomes a bane of problem selecting the cases. Because, to say that this is only, chronic fatigue syndrome, that becomes difficult, though a way out is that it has to be preceded by an evidence of infection. Now, it is not always a very helpful one. But in the process that you do get sensory disturbances, and to look at it in terms of brain mechanisms, how can you understand what is happening in terms of various sensations? What Dr. Sanjay Kumar has taken, the cognitive EP or evoked response potentials, whether it is P50, whether it is P300, mismatched negativity, and neuropsychological batteries, the CANTAB. I think all put together a very complex, a very common, but paradoxically not commonly diagnosed condition. How to understand it? How to understand, the mind-boggling sensory disturbances that these individuals have. In clinical practice, they are the people who will come and tell you that there is, temperature in the bone, fever in the bone, the steam is coming out of head, the body is burning, the vision is difficult, painful, hearing is difficult. How to understand it in terms of brain mechanism? This is a very meaningful talk, and I congratulate Dr. Kumar, also the organizers, that they have taken this topic, also that they have involved me. Thank you all. Thank you very much. I move on.
Thank you, Dr. Nizami, sir, for your valuable insights and reflection. Your perspectives have added great depth to today's discussion, helping us connect clinical research and neurological insights into practical interventions. Now, I would like to invite Professor S.Z. Sedi, sir, to say a few words.
Good afternoon, Dr. Huck, and good morning, Dr. Sanjay. Thank you very much for sparing your time and giving very scholastic presentation, and in spite of your busy schedule, and you agree to our request. Dr. Huck, particularly you, because I know that you are very busy otherwise also. And last couple of years, you have not been very much out of your city and attending the conferences, but you have agreed to my request. I am personally obliged for that. And it was a very good session, and your contribution, your sharing of knowledge must have enriched our students and participants. Thank you once again, Dr. Huck and Dr. Sanjay. Thank you very much.
It's been a pleasure.
Understanding the neurological underpinnings of sensory processing challenges is vital for improving interventions in chronic fatigue syndrome. A research progresses, bridging the gap between neuroscience and clinical practice. It is essential in advancing effective therapeutic approaches and patient care strategies. With that, we conclude our lecture sessions for the afternoon. The insights shared today have deepened our understanding of mental health in the digital age and neurological factors influencing clinical conditions. A heartfelt thank you to both our esteemed speaker, Professor Dr. Afzal Javed sir and Dr. Sanjay Kumar sir, for sharing their invaluable knowledge and with us. Our sincere gratitude also goes to our esteemed chairperson, Wing Commander Dr. Anil Tiwari sir and Dr. Haq Nizami for their guidance and contribution to these sessions. Up next, we transition into the valedictory ceremony, where we reflect on the insights gained, recognize outstanding contribution, and celebrate the success of this conference. We invite you all to remain seated as we move into the closing proceedings. As we come to the conclusion of this prestigious two-day international conference on community health and integrative approach, it is time to reflect on the knowledge shared, the collaborativeness fostered, and the invaluable contributions made by our esteemed speakers, participants, and organizers. These past, those, these past 2 days have been filled with enlightening discussions, thought-provoking research, and expert insights that have deepened our understanding of community health, mental well-being, and neuroscientific advancement. It is our great honor to welcome the chief guest of this valedictory ceremony, Wing Commander Dr. Anil Tiwari, Sir, Pro Vice Chancellor, Amity University, Lucknow. Sir, please join us on the dais. I would also like to request Professor S.Z.H. Zedi, Sir, and respected Professor Dr. S.P.K. Jaina, Sir, Senior Professor, Department of Applied Psychology in University of Delhi South Campus. Thank you for joining us, sir. To summarize, the key takeaways and achievements of this conference, I now invite the organizing secretary, Dr. Sajid Kazmi, sir, here.
Thank you, Himkriti. Good evening, everyone. I'll not take much time of yours because I know this has been a very enriching journey of last 2 days. So conferences like this give us a platform for networking, for enriching our knowledge, and for some kind of revision as well. That is why this RCI norms of CRE, so that you are uptaking of information and updating of our information should not stop. So over these 2 years, we had a plethora of speakers joining us from different, not only part of India, but from abroad as well. To name a few, we had speakers from United Kingdoms, we had speakers from Netherlands, we had speakers from Australia, and esteemed speakers from different universities of India. To give the exact report of the overall gathering we had here, so we had the presence of 323, that is the 323 participants registered for this conference. And amongst them, we had 49 RCI registered professionals who are amongst us, who are representing different specialties from the rehabilitation profession. Amongst the 323 registered participants, we had 220 participants who are in the offline mode. They are with us in the physical mode. And rest more than 100 participants are in the joining us from different part of the India as well as abroad in online mode through Zoom. Apart from this, we had around 10 lectures in the form of invited lectures, starting from our keynote lecture delivered by Dr. Rakesh Lal sir from AIIMS, followed by Jena sir. Then we had Kirmani sir from MIT Gurgaon, then Rakesh Tripathi sir from KGMU, Dr. Vivek Agarwal from KGMU, and so on and so forth. In addition to that, we had 13 scientific sessions over the period of 2 days, 10 in the physical mode and 3 online sessions, in which more than 100 research papers from different fields, interdisciplinary areas have been presented. And you all have been, I definitely hope that you all have enriched from it. Regarding CRE participation, just a few points that whosoever is still left out, we have the attendance sheet out there because it is one of the mandatory criteria. So if any of you is still left out to sign this RCI registration sheet, please do that before we conclude this thing. And your CRE certificates are with us. We will proceed for the certificate distribution shortly. Thank you very much.
Thank you, sir. A conference of this stature is made successful just not by the speakers and organizers, but also by the active engagement of its participants. We have had the privilege of hosting renowned experts, researchers, academicians, and students, all of whom have contributed immensely to the depth and diversity of discussions. As we move to an important segment of this ceremony, the announcement of results and distribution of continuing rehabilitation education certificates to recognize the outstanding contributions of the participants in the conference. The best paper award would also be rewarded during this ceremony. I now invite Ms. Bhavini to call out the names of the participants. I also invite I also invite Wing Commander Dr. Anil Tiwari sir to please felicitate the participants along with Professor SZH Zedi sir. I would also like to invite I would also like to invite Professor SPK Jaina sir to felicitate the participants.
Good afternoon, everyone. Before I begin calling out the names of the winners, I would like to request all the CRE participants to sign a sheet with Ms. Himkriti ma'am before you leave the room, please. Okay. So the moment you've all been waiting for. Under the subtopic, Community Mental Health and Well-Being, the award for the best paper goes to Attachment Style and Sexual Motives as Predictors of Sexual Behaviors Among Young Adults, co-authored by Ms. Akhila S. Kumar, along with her 3 co-authors who will be also awarded. Please come on stage, Ms. Akhila S. Kumar, Ms. Vanshika Walia, Ms. Suhani Khandelwani, and S. Manushi. Okay. So under parallel session of the sub-team theme Community Mental Health and Well-Being, the award for the best paper goes to The Roots of Hoarding, Exploring the Links of Early Maladaptive Schema by Ms. Pratishtha Sharma. Under the sub-theme of Integrated Community Medicine, the award goes to Effectiveness of Art-Based Therapy on Aggression Among Oppositional Defined Disorder Adolescents, a follow-up study by Ms. Himani H. Soni. Under the sub-theme of Education and Information Empowerment for Community Health, Geriatric Health, Palliative Care, and End-of-Life Care, the award goes to Verbal Learning Style as a Predictor of Academic Achievement Among High School Students by Mr. Siddhant Appukattam. Under the sub-theme of community mental health and well-being, the award goes to coping mechanisms of transgender individuals and their propensity towards criminalization and victimization by Mr. Aviral Srivastav. Under the sub-theme of spiritual health and Indian knowledge system, the award goes to mindfulness as a predictor of alexithymia among the patients of polycystic ovary syndrome by Dr. Shivani R. Joshi. Under the sub-theme of health policy management and healthcare delivery, the award goes to case study supportive psychotherapy for a primary caregiver of a child with intellectual disability by Ms. Nabanita Barwa ma'am. Under the sub-theme of health promotion, under the sub-theme of health promotion and disease prevention, health and biostatistic, the award goes to acceptance of illness and medication adherence among patients with multi-drug resistance, TB, a cross-sectional study by Mr. Swatantra Kumar. Under the sub-theme of health promotion and disease prevention, health and biostatic, the award goes to diabetes-related distress and cognitive functioning among middle-aged adults with controlled and uncontrolled type 2 diabetes, a pilot study by Ms. Shreya Roy. Under the sub-theme of occupational and rehabilitative interventions, the award goes to role of depressive symptoms as a mediator for self-silencing and expression of anger in women by Ms. Prerna Sharma. With that, the awards for the best papers have concluded. And now I would like to request our CRE participants to please listen for their names and come on the stage to receive their certificates. Please wait for a moment. Uh, there's been a change of plans. You will receive your CRE certificates at a later time. Thank you, everyone.
It is our great honor to welcome the chief guest of this valedictory ceremony, Professor Dr. S.P.K. Jaina Sir, Senior Professor, Department of Applied Psychology, University of Delhi, South Campus, a distinguished academician and expert in applied psychology, mental health research, and community intervention. He has made outstanding contributions to the field, shaping both policy and practice. His dedication to education, research, and community engagement has been instrumental in advancing mental health and well being. We are privileged to have him with us today. Please join me in welcoming Professor Dr. S.P.K. Jaina, sir, with a round of applause.
Very good evening, everybody. We really enjoyed these wonderful sessions, the International Conference on Community Mental Health, Integrative Approach. In the beginning, we started with lighting the lamp. Lighting of lamp symbolizes ignition of our own cognitions, our thoughts, our insights. And with this ignition, we carry on to have many sessions in which we have heard from the stalwarts in the field who have been worked in this area. Universities have been transforming themselves, and this transformation is towards the community. The earlier model, biomedical model, which was an individualistic model, is transferring into a community model. We must appreciate this move. And in this context, this seminar is really very interesting seminar in which we joined our hands together to listen to all these speakers. Now we have a long way ahead to travel. We have to traverse a long distance, although there is an ignition, there is a kind of thought revolution. We have to continue to maintain this kind of understanding and transfer the knowledge to the community. Now, when we talk about community, this community is not just slums and people who are around us, but also would like to see that the community also comes to the university to be participant in our programs and prospects. So it is a two-way process, and probably this beginning has started with this. And I must appreciate the kind of involvement of the students, the participants, and people who have contributed to this particular area. And I feel that this will have a long-lasting effect. Of course, we appreciate the kind of hospitality which is being extended to all of us. It is a wonderful occasion to have this kind of experience. And I must thank Professor Jaidi, Wing Commander Tiwari, and the officials of the Amity University to make this occasion a successful occasion. Thank you so much for being a part of this wonderful occasion. And I feel proud to be here with all of you to share this trail. Thank you so much for your time.
Thank you so much, sir, for your valuable words. It is our privilege and our honor to have you here. Thank you so much. I would now like to invite Wing Commander Dr. Anil Tiwari, sir, to deliver the valedictory address. Okay. At this time, I would like to invite a few of our participants and students to share their experience and insights gained over the past 2 days.
Yeah, can you hear me?
So my name is Dr. Randhir Singh Yadav. I'm from HTT University. I'm an assistant professor there. So I'm little new to this field, just about 7 years old. I'm ex-army data brigadier. It's always been wonderful to be in this kind of setting. I like the environment, academic environment, especially conferences where your horizon widen and it motivates you to further explore the new areas and update your knowledge. And especially here, I always wanted to come to MIT University Lucknow. I had some kind of desire to come and uh, see experience the environment here, and it was really nice to be here. And the way this conference is organized, even we have been organizing conferences on a regular basis, on an average at least 2 in a year, but there's always something to learn, something new. So this I've been observing very closely, monitoring very closely. I'm sure we'll incorporate this aspect in our further, conduct of conferences in future. Thank you very much. Thank you very much, sir.
Thank you, sir. If anybody else would like to share their insights over these 2 days conference.
Namaskar to everybody present over here, dignitaries on the dais. It is indeed a very valuable opportunity for young budding scholars and researchers in this field. And I'm very thankful to the organizers for making these 2 days even more enriching for us. And yes, such conferences should happen, and there is a great requirement for psychology conferences to be arranged on regular basis in order to gain more and more knowledge about it. So thank you so much. Thank you.
Thank you for sharing your kind words. Now we move on to the another important segment of this ceremony, that is to call out participants for their CRE certificates. For that, I would like to call upon the stage Ms. Bhavini Tiwari.
Good afternoon again, everyone. I will now call out the names of the CRE participants. Please come on the stage to take your certificate. Miss Anamika. Thank you so much, sir, for your presence and your wisdom. Before beginning, I would once again like to remind all the CRE participants, if you haven't signed your name, Miss Himprati will have the list with her on that side of the auditorium. Miss Anamika ma'am, please come on stage to receive your CRE certificate. Miss Sarina ma'am, please come on stage. Miss Neha ma'am, Miss Sushmita ma'am, Miss Anvesha, Miss Pankhudi, Miss Purvai, Miss Garma, Mr. Randhir, Miss Shreya, Miss Srishti, Miss Anshuma ma'am, Miss Sonali. Miss Divya. Miss Neerja. Miss Nandini ma'am. Miss Ankita Singh. Miss Ankita Saha. Miss Geeta. Miss Ayushi. Miss Saima. Mr. Safal. Miss Prachi. Miss Shazia. Mr. Syed Sajid Kazmi. Miss Iram Naz. Miss Himpriti Sharma. Miss Deepanjana. Mr. Mohammad Ehsan Khan. Miss Neelam Bansal. Miss Anamika. Miss Davanita Barua. Mr. Swatantra Kumar. Miss Seema Saraf. Correction, Dr. Seema Saraf. Miss Poonam Singh. And Miss Shrishti. Miss Pratishtha Sharma. Miss Priyanka Singh. Correction, Dr. Priyanka Singh. Miss Pratishtha Pal. Miss Prerna Sharma. Miss Srishti Sahu. Thank you to our CRE participants. I would now like to invite Wing Commander Dr. Anil Tiwari sir to deliver the valedictory address.
My esteemed colleague, senior colleague, Professor Zaidi, distinguished guests, our fellow colleagues from other amateur universities, ladies and gentlemen, boys and girls, it's been sheer delight to be part of this International Conference on Community Health and Integrative Approach. At the outset, I would like to compliment Professor Zaidi and his team for organizing this mega event. International conference is a great meeting point for youngsters and seasoned academicians to share their thoughts and the new findings. I place on record my deep appreciation for all the eminent speakers who joined us from abroad and from the distinguished assignments within the country. I think there could not be a better place to host an event than Amity University Lucknow campus. They say it's the heart of the country, and I hope you enjoyed our hospitality. Lucknow is known for its hospitality. So once again, मुस्कुराइए कि आप इस कॉन्फ्रेंस में लखनऊ में हैं. The topic that we deliberated upon, community health and integrative approach, is so relevant to the society because it's a matter of interdisciplinary nature where all healthcare professionals come together. Hence, we saw a very large number of participation with about 350 peer-reviewed publication. I can say that would be a record for any good conference. I'm very happy to note that this conference has paved new pathways for research. And I would urge upon all the participants to utilize the networking that they have built. There have been eminent guests abroad, and I've told Professor Zaidi to make sure at least some of our scholars, minimum 10, visit across to United Kingdom and participate in person, do research under our study abroad program, which is very, very important. I once again place my deep appreciation and hope and pray you have enjoyed your stay intellectually and with the hospitality that we could extend you at Lucknow. Looking forward to another version of international conference next year in a stronger manner. And I would say, sir, this time we should go in for a Springer publication. So that's the kind of a target because it attracts the best of the best and your peer review could be at a much, much higher level. So with these words, my best wishes to each and every one. Jai Hind. God bless you.
We are deeply grateful for your inspiring words, sir. Your presence has truly elevated this occasion. Alone, we can do so little. Together, we can do so much. These 2 days has truly been a testament to that spirit. As we come to the end of this incredible journey of knowledge and collaboration, it is only fitting to express our heartfelt gratitude to everyone who made this event possible. The speakers, the participants, the organizers, volunteers, and the supporting staff. Thank you for making this event a resounding success. Before we conclude, I request everyone to rise for the national anthem.
नायक जया है भारत भाग विधाता पंजाब सिंध गुजरात
Thank you, everyone. With this, we officially conclude the two-day international conference on community health and integrative approach. Before we disperse for the evening, I invite all dignitaries, speakers, participants, and volunteers to join us for a group photograph on the as a lasting memory of this remarkable conference.